I think maybe let's begin. Ladies and gentlemen, good afternoon. I'm C.C. Wang from China. Now this session, I'm the moderator. And this session is enhanced recovery after bariatric and metabolic surgery. So we have several speakers, but about half is video because from China, pandemic lockdown, very difficult can come here. And another moderator, the session chair, Muhammad Ali, because visa problem, so he also can come here. So the first speaker is Dr. Ashwin Sabra. He's from Singapore. Also, we all know Ashwin is very famous in bariatric metabolic surgery field. So his topic is perhaps the key to success recover. So welcome, Ashwin.
Thanks. Thanks, Professor C.C. Wang, for that very kind introduction. So thanks to the organizing committee for the topic. The topic is prehabilitation, the key to successful recovery with a question mark. So what is actually all this all about? What is this concept of pre-surgical candidates going through therapy for various modalities that are designed to take care of their physical, psychosocial, metabolic, and psychosocial reserves? Basically, this is all about prehabilitation. Does it have any relationship with obesity? We know obese patients are slightly higher risk as compared to the other patients on a normal day-to-day basis. Success, as we just discussed, doesn't depend on the surgeon alone. There's also a patient preparedness for the surgery. And what we can do is intervene at multiple levels to improve the outcomes. So what are the possible prehabilitations we could do? We could ask them to quit smoking, quit alcohol. We could do some preoperative weight loss and then induce exercises that can strengthen them in order to achieve various outcomes. So let's look at them one by one, and we'll go through this prehabilitation phase in bariatric surgery. Smoking, as you know, is associated with increased risk of marginal ulcers and infectious and respiratory complications. There are a few systematic reviews that you can go and review them. They've reviewed about 28 that they were the systematic review that reviewed about 28 non-randomized controlled trials and reported a reduction in the post-operative morbidity of morbidly obese patients undergoing bariatric surgery. So when is the optimal time for cessation? There is no consensus, there is no data when they should, but extrapolating from the general surgery data is generally considered that 4 weeks before surgery, we should tell them to stop smoking and use nicotine patches. As most of you would know, that a very large cohort of yours and mine will go back to smoking again. And that's the bigger downside. But at least for the portion of the anesthesia, they're fitter, they have less sputum production, they get fewer respiratory complications. Alcohol. The evidence of recommendation in bariatric surgery for quitting alcohol is low. All right. Now, when I talk about quitting alcohol, I'm talking about high alcohol intake. I'm not talking about the glass of beer or the occasional glass of wine here. I'm talking about tipsy every day, every night. That's not on here. All right. So why is it important? Because it increases the risk of postoperative complication and infection and wound complications. And it's a complex behavior. And we've seen from a number of data that came out from the sleeve and the bypass, showing that these people are basically at a risk of behavioral interventions and changes over time. And they do go back to this drug addiction ultimately, and that results in poor outcomes in this. So what do they recommend? The general recommendation is you currently have to make sure that they are off this habit for a year or two before you operate on them if they are chronic high alcohol intake patients. Because by then they would resume back to their habit if they had to. Now let's look at preoperative weight loss. An interesting era. A lot of trials done around it, some randomized, some observational studies, did not show much outcomes in terms of pulmonary function, cardiac function, and many others that study. But is it important? It is important. What do you do for a week or two? So about 2 weeks to 4 weeks of low-calorie diet, which goes up to 1,200 kilocalories per day, or a very low-calorie diet, which is about 800 kilocalories per day. That's what, like a sachet of Optifast is 300. That's less than 3 sachets of Optifast a day. So you need to make sure that they keep hydrated and can eat salads. What has it shown? What's the literature about it? It's shown to reduce liver volume, which is pertinent to surgeons. You can lift the left lobe of the liver easier. You have fewer injuries and morbidities to it. Your surgery is smoother. We were talking about mesentery and the mesentery not being able to bring the small bowel up to do the anastomosis. It becomes much more, because the first component of fat that you lose when you lose the first few pounds is actually visceral fat, and it makes your omentum and your mesentery very soft and pliable, and it can come up. And secondly, insulin resistance decreases and sensitivity increases, which means metabolically the body is healthy. And obviously surgeons' perceived complexity of the procedure is easy, especially with that very big left lobe of liver. So diet. We talked about diet just a while ago at lunch symposium. The general recommendation is 5% weight loss to pre-op weight loss. And most of the studies have examined this and agree that 5% is where we should be. We in our study actually looked at 8 randomized controlled trials. Only 5 kinds of diet were able to achieve this. And those that achieved it actually had anywhere between 700 to 1,500 kilocalorie diets consisting of moderate carbohydrates. Right? We are not talking about very low carb diet here. We're talking about intake of moderate carbs, high protein, and definitely low or moderate fat for 3 weeks is likely to give you, on a home-based diet, about 5% weight loss. A low carbohydrate diet, which is less than 20 grams per day, you can achieve this target a bit more earlier. And I tend to do these for my patients who I admit for very low calorie diet. Now, the effects are evaluated in an ERA setting and showed that if you do this preoperative weight loss, you reduce operating time because you don't have to struggle with the big liver, with the mesenteries, and you improve post-operative weight loss outcomes. Reduce post-operative complications, especially respiratory complications and surgical complications. They are associated with surgical complication reduction, intervention complexity, and length of hospital stay. I think the length of difference in hospital stay is about 2 days. So they go home, those that you have pre-op generally go home on day 3, while the others stay about 5 days. And then this systematic meta-analysis said that you can have more weight loss as it. What do we know about prehabilitation in the sense of exercise? We know that obese patients, preoperatively, they are less physically active, and it is associated with a reduction in cardiometabolic risk and premature mortality and postoperative complications. So getting them to be active is something that is important, and we should do that. Improve postoperative pulmonary capacity because of decreased abdominal adiposity, visceral fat, which pushes the diaphragm up, increases the respiratory compliance and resistance following prehabilitation of inspiratory muscles, and they do much more better. So the IRAS Society in 2016 then brought the concept of what is called prehabilitation into their protocol. So smoking, alcohol, preoperative weight loss was there, but this prehabilitation came in 2016 where they said it's going to improve their respiratory compliance and muscular function, and we should encourage people. And as you saw at the IFSO data, they want to increase the age. As people age, they lose muscle. We got to get them back in. So this includes intervening to increase physical function before surgery and returning, improving recovery and reducing morbidity. And it's shown in meta-analysis to reduction in post-operative morbidity in prehabilitated group. Composite pulmonary morbidity endpoints are much better and lower in these patients who go through prehabilitation, and borderline significance on the length of stay is also seen in this recent publication that I'm going to show you. This is what you do. Right? Before prehabilitation, you get this person who is non-prehabilitated. You increase his exercise tolerance and performance up here. When you perform a surgery on him, he dips down below the normal basal level, but he doesn't dip as far as these people who are not prehabilitated, and eventually bounces back much earlier as compared to the other cohort above normal, which is great in terms of outcomes. If you look at bariatric surgery in particular, what you're seeing is a very small number of RCTs with about 12 weeks of exercise program, including endurance training associated with reduced weight, that's expected, cardiometabolic risk factors, as well as improved general fitness in these patients. The 6 weeks preoperative training program in this study that I would show you in a while, was associated with maintained improvement in physical activity as far as 6 months. So the patients continue their cycle. And secondly, as a result of this, even as early as within few hours after surgery, you can see that they have much more better oxygenation because you teach them respiratory. One would seem that this is rather easy and to do. And just to give you a flavor of it, look at the intervention that this group did, all right? Avoid UV radiation exposure. Maybe difficult in our part of the world, all right? Walk at least 30 minutes a day. That's almost like teaching them normal lifestyle. 5 to 5 minutes of warm-up, cool-down practice. Okay, and this is just journal. Now let me go to the specifics of it. Intervention. So that is standard program, plus half an hour specific training, increasing physical activity, functional capacity, and muscle strength. How do they do that? Spirometry, inspiratory valves, and this elastic non-latex resistant bands. Look at the protocol. How often do you need to exercise? Twice daily for 15 to 20 minutes. You need to receive spoken information, written information, video information. You do 4 resistance exercises with the elastic band. So it is exhaustive. It's not easy to be doing this. And so you need a team to follow up your patients. So that means we need to select our patients who would really benefit from this. Is a 30 years old who is otherwise agile and moving needing this? Maybe not. Somebody who's 65, maybe yes, would benefit from this, all right? And this is just the respiratory component of what I copied from the trial. It's intense. Even I can't do this. You know, I don't have the time to do this. So what is the difference? Yeah, this is leisure sports. All right, this is not leisure sports anymore. All right, this is what you're telling all bariatric patients to do, which is not going to be the case. And that's why the outcomes in literature, the trial that I showed you started with some double-digit numbers of patients. At the end of enrollment, their outcome was 5 patients. So they were embarrassed enough not to even publish their results. All right, so that's how difficult it is. You can regiment people as long as they're under your control, but not above here. Right? With that, this is the new IRAS paper, and I would like people to refer to this paper. And it says prehabilitation. The evidence available is low and recommendation is weak. But maybe for a select group of people who have basically deteriorated, this is a great intervention. With that, I come back and say thank you very much.
Very good. Any question?
That's good.
Good. Thank you. Actually, I have a question. Just in Singapore, how after operation, bariatric surgery, how long to go back?
So most of my patients go back on the third day of their surgery. So I operate on Monday, Wednesday they're home.
That's good. If long time, maybe make more money.
I don't make money, so the hospital makes money. Oh, patient. Yes. So the thing about our health system is we are unique in the sense that we are a public entity, but the patient contributes to the system, and some private insurance also pay. So, but I think for the patient, it is better that the patient gets home, and they prefer to recuperate in their home, in their friendly environment, than staying in the hospital. So most of them, but some people like post-transplant, people on very high dose of steroid, those who have intraoperative complications, or those that do not follow the normal expected outcome and standard of outcome that I would have expected, like they start getting tachycardic on day one, I would not send them home. I watch them a little longer. So that's
Good. In Singapore, if sleep gets to me, have day surgery.
No, we don't do day surgery. So the problem with doing day surgery is you need to counsel the patient. The patient needs a lot of pre-operative counseling, and I lost my only coordinator about 2 years back, and I don't have that luxury of reinforcement. If you have it, then it is doable. I've done it before, but not in the current state. You need a very strong multidisciplinary team to make sure that at the back end, the patient doesn't get dehydrated, the patient doesn't have other problems, there's somebody to look after the patient. So I know in the European countries, I'm not sure about Australia, but I know in the European and the US countries, they say, oh, go home in 23 hours, go where? Next to in the hotel. And the doctor comes and visits you in the hotel. I'm not sure whether that is discharge. I still call it a step-down hospital, a step-down care. So to me, it's not truly. We have devised another program led by Dr. Darrell. What we're going to start is we have a group after COVID came. We have a group of nurses and dietitians, physiotherapists, who actually used to go to visit the patient at home with the doctor if they need help. They're actually fit for discharge. So we're going to reignite that service. So we're going to start sending our bypass patients, sleeve patients home, but they will offshore monitor all these patients. And if they're well with that, then they will be going home within 23 hours of their surgery. I think going home the same day, I find it a bit risky. If I've kept them over 23 hours, no tachycardia, no exuberant pain, nothing, fine. They can go home. Somebody else can follow them up. If there's any problem, they can come back to us anytime. We're welcome.
Like Singapore, Hong Kong, because the patient may be same city, maybe me easy. If after
Yes.
complication happen, maybe come back, go back.
Yes.
But in China, maybe the patient is 1,000 kilometer away. So
Yes.
that's a bit more danger.
Yeah, so I think and this is not only your problem. I think this is a problem for many Asian countries who are humongous. So if somebody wants a bypass done in Miami and he flies over to New York, he always knows he can get help in New York if he runs into complication. Right? But if somebody flies, for example, in India, let's say, for example, somewhere down south, he does not know if he flies up north, he will find a bariatric surgeon or not. You know, so if I'm a surgeon there, I wouldn't let my patient go. I don't care what the world tells me about my length of stay. I don't give a damn to it. Right? I'm more concerned of what I give to my patient. Right? The world can say, oh, you discharge him 23 hours. You discharge 23 hours, you send to a hotel. To me, it makes no sense. Right? I discharge 23 hours. I discharge 5 days down the road. I make sure my patient is 100%, and I know that my patient is safe at home. End of story. That's how I do it. Thank you.
Thank you. Thank you. Very good presentation. And Professor Imna, who is Imna? Not here. So we invited the second speaker, Dr. Sim Wong. He's from Hong Kong, China. He also is president of Hanggang society. Okay. Today his topic is intraoperative circuit for an amazing recovery. Welcome.
Thank you, everyone, ladies and gentlemen. I'm very honored to be able to come here and speak on this topic, although I just learned about I need to talk about this topic 3 days ago. And if you look at the topic, you may find it is a bit tricky for me because I think Azim had told you what is IRAS program and what is our aim is to make the patient have a better recovery with a more smooth early mobilization, and overall experience is good. So in this IRAS or early recovery program, I think the role of surgeon, especially for intraoperative, is the one role is just to make sure that you don't have complications. I think that is the most important. So, but this is, you can spend another 3 hours lecture next door. So I'm not going to talk about this. So what you need to do is that you need to make sure your technique and your volume and your confidence on the patient is okay before you want to start IRAS program, because it is a program that is a very well planned and with a clear clinical pathway. But for intraoperative, equally important for the speedy recovery of the patient is, I think, is to find the right anesthesis. I think that is the very important issue. And especially for me, I think that this is my intraoperative secret of recovery. So for anesthesis, I found my own. This Dr. Cindy Choi in my hospital. She is a brilliant anesthetist. She is specialist in cardiac initially, and now she's very interested. And of course, all of you may have your own special anesthetists. The most important, I think you all know, they need to be work together as a team, a multidisciplinary team, know the surgeon well, and they should have their own role of assessment before and during surgery, and they should have follow-up. I think, and this is also have integrated discussion with other collaboration like dietitian and psychologists to know the patient's needs. So for the next few minutes, I think most of this PowerPoint is from Cindy, so she helped me a lot. So I think IRAS is a field that is very hit in these few years. It started with a colorectal program, and then slowly it moved to other programs, and bariatric is one of them. And when you look at the recovery, or when you look at the bundle suggested by IRAS Society, they have several bundle of protocol that you try to follow. Some are preoperative, as mentioned with Azim, that the patient need to be prepared. They should, before surgery, some of them need to have good pre-op weight loss, some will need to have quit alcohol and smoking, and they should be educated and well planned on their journey that they let them need to know, and also we need to assess them thoroughly before we continue this IRAS. During surgery, it's a bit tricky. Although we try our best surgical technique to reduce complication, and with the good volume, you may be able to do this, but something is less controlled by me or controlled by surgeon is the medication or the fluid management during surgery. But the main issue is we try to limit the fluid intake during surgery, and we try to use medicine that can let much less post-op nausea and vomiting. And for surgery part, I think the most important is when your technique is good enough, try not to put any drinks, not NG tube, not Foley, or not drinks in the abdomen. So without all this, your post-op recovery will be much faster. Of course, obese patient is very complex. They have different physiology. So our anesthetists should have their own protocol, how to manage different scenario and different type of anesthetic that they use. And also for respiratory or airway management, they should have different airway management protocol by use different strategy and gadget. Of course, still at the depth of anesthesia, the type of drug that they use, you need to monitor. So it is also very important for them to have their own method of doing it. And also pain control is a very important issue. both intraoperatively and postoperatively. And we always may need to use multimodal anesthesia during the surgery and tie over them and continue as post-op surgery. Of course, for ERAS, we also include post-op bundles, which include the oxygen control or oxygenation, as obese patients are more or less a lot of sleep apnea problem. So this need to have a protocol to follow, and also early diet refeeding and prophylaxis is also important. But we also mainly concentrate in intraoperative surgery. But nevertheless, with multiple meta-analysis, we already know that ERAS program did reduce hospital stays by 1 to 2 days in many studies. And although in many different studies, they may have different elements included in this study, but the most important part in ERAS recovery is that post-op nausea and vomiting is the major determinant factor for a delayed discharge. And also, high intra-op volume input and low oral diet post-op is also a factor that will reduce or delay the discharge. So this is the area that we always need to put in. And for operation-wise, the drug we use, we always try to minimize the post-op nausea, vomiting. And different studies have different strategy. Most of them is the use of steroids together with anti-emetic, the 5-HT antagonists together with dopamine. But in Asia people, as we know, we have high preference of diabetes and high preference of sleep apnea. And for our center, when we review our 2-year data, we found this is 50% of patients with diabetes and 90% of sleep apnea. So this is a high-risk group patient. And can ERAS program really apply to apply safely in this group of patients? So we try to assess it within our own surgery cases cohort. So we try to review it. So with the bundle suggested by ERAS Society, we also add some pre-op program, such as pre-op stop band score to make anyone who has high risk of sleep apnea to undergo PSG before and then receive CPAP at least 4 weeks before the surgery. Another category, we also assessing how good we comply to our protocol on this program. Some of these mainly for intraoperative is the use of drugs during the surgery and the lung protection strategy. So ERAS or intra-op monitoring method is not just one element. It's a cocktail of different bundles during the surgery we need to monitor. For example, the bundle of how to manage the airway is important. When the patient, before intubation, they need to put in a good position. We use the throat pillow, which is a good pillow that to extend your neck, extend the patient necks and make it easier for the intubation and airway access. And also we may use other gadgets to help the anesthetist to put in the ET tube. And also for analgesic and anti-emetic and anesthetic, the different anesthetists had different strategy of timing of dose or how to calculate the dose that you use. So this is all in their specialty, but this is very important part because this, how good you use it will govern how they recover. And what we mainly try to avoid is post-op nausea, vomiting, and pain after the surgery so that they can speedily recover. So, for example, for nausea, vomiting in our center, this is our protocol using steroid dexamethasone before the procedure, and during we titrate the anti-emet or densitron, and then afterwards we give metoclopramide. And also for pain control, we believe on opioid-sparing methods. So in the whole surgery, we try not to give any morphine or opioid. So we titrate different kind of drugs during the surgery. And this is a very complex procedure, and my anesthetist will know how to use them. So I just can name them for you. We use several different drugs. Like nowadays we have intravenous paracetamol, so that is useful and it's peak out for an hour and have long durations. And it can be used during the surgery. Paracetamol is a intravenous COX-2 inhibitor. This is also very useful for pain control during the surgery. Some upper GI surgeons don't like it because of the gastric effect, GI effect, but actually this is not that worry if you just use for a very short period of time. But of course, if the patient have renal problem, you need to be careful. And also for other pain control and anesthetic control, we use a cocktail of these different drugs, like we use desmibits to minimize for the sedation as part, because they are patient will be less respiratory suppressed and have a better recovery afterwards. And also we use a lot of ketamine, which is an Asian drug, although it's a drug that some people abuse, but for anesthetic, they cause a dissociation state that patient experience is better and they can have a lighter anesthetic sometime. And also we also use lidocaine infusion during the surgery as well, which can also help to reduce the anesthetic leak. And of course, after the surgery, we will give some long-acting wound infiltration of buprenorphine for pain control, because it's know that it is good for post-op pain requirement. So with all this bundle of checklists, we have gathered our data and see about 60 patients. We found most of our patients can follow this protocol. Just a few of them is not to 100%. And this how to ventilate, how to give analgesic, and how to give opioid analgesic. But at the end of the day, we found our pain score during the surgery, most is in the day 0, but afterwards it's really below. Most of them is well-weight pain control. Hypoxia is minimal, only 2 out of 60, and only 5 of them, less than 10%, have post-op nausea and vomiting in day 1. Afterwards, they don't have. And also, during the pain control period, only 7 of them have received some additional opioid, like tramadol. But other people seems very good recovery. So our recovery time is about discharge time of 3.2 days. And we don't go for day surgery at our center and our hospital. We want to make sure after surgery they can have adequate fluid intake before they leave hospital, and when they can mobilize. So we have a criteria of discharge. Once they reach that, we will get them home. So during this period, we don't have any complication, and we don't put any drinks on these patients, so they go home early. So at the end of the day, I think ERAS, although it starts with colorectal cases, but I think it can also apply to upper GI cases and also bariatric cases. So it all depends on how your team and how your anesthetist to gather all the patients' educations and your team to work together to achieve this kind of program. And then you stick to your clinical protocol, and then you select which patients are good for this kind of management, and then you may have a good result. Thank you. So now I'm in the Prince of Wales. I have my team at there. So now I move to the new hospital in the CUHK Medical Center. But of course, I will bring my anesthetist with me. So now she is with me in the new center. So if time allowed, you may come to Hong Kong, and we will visit us in our hospital. Thank you.
Thanks. Any question? Sam told us all the secret about the ERAS. Now you move the new hospital, maybe can did more bariatric surgery, maybe.
Yeah, we can have schedule more of this, but still, because public hospital is different than private, you need to pay by your own pockets. So it's a different story on this side. But we will try to build up our cases with a new program that is giving. So, but our hospital is just 1 year old, so there's still time to develop.
Now, the Hangam can do the endoscopy balloon.
Yes, we do endoscopic balloon. Yes, sure. But that usually a day case, except some patients is worried that they cannot come back and nausea, then we will give them overnight stays. So, but we give a very strong antiemetic before, especially before the surgery, so make sure the first 24 hours can have good antiemetic. We even give those chemo type of a long-acting antiemetic, and all this will be useful. Yeah.
Okay.
Thank you.
Thank you.
Yes. that will, if you doubt, call your senior. That is the most important. Don't just stick your head inside and struggle.
Thanks.
Thank you.
Thank you.
Thank you. Thank you, Sam. The next speaker is Dr. Alex Craven. I'm sorry, they introduce. You have the. Welcome. So, Alex is come from Australia. His topic is patient selection and the program enhancement for biological surgery in a low acuity center. Please.
Thank you. Hi, thanks for having me. It's my first IFSO, and I like it very much, so thank you all. I'm going to talk about patient selection and also program enhancement, but I'm probably going to talk more about enhancing your program because I think then patient selection just comes hand in hand with that. And this is based on my observations of our program in a low acuity centre, that is one with no HDU, ICU or senior medical staff available after the recovery room closes and the lessons we've learned. And I offer three things for consideration. The first is that maybe ERAS is best used as a basis for forming effective and empowered teams rather than just protocols and chasing compliance on those. The second is that extending ERAS beyond just the immediate perioperative period, but across more of the patient journey also brings some big opportunity. And third, that rather than a static set of guidelines for us to follow, that perhaps there's opportunity in developing our ERAS so that it's a continually evolving and improving program over time. I'm going to try and use this this polling thing, so if you could all pull out your mobile phones or laptops and go to pollev.com and enter AC638. I will not be stealing your credit card details, don't worry, but there'll be, so people, if anyone's listening online, they can join in as well. I have no conflicts to declare, but my most important disclosure is I did not make this program. I was not involved in its design or implementation. I just came along late. I benefit from it, and I'm learning from the team and the program as I have joined it. And in particular, I'll acknowledge Ahmed Ali, my colleague, friend, and mentor, who was supposed to be here today, but unfortunately couldn't make it. He's the leader of this program, and a lot of the credit should go to him. So first of all, who has a ERAS? Do you have one now? Have you had one for a long time or somewhere in between? Good. So most people have an established ERAS and some are working towards it, so that's good. Ours has been in place now for about 5 years, and I guess here's some of the lessons we've learned. The story of our ERAS started as a need to grow the unit, and unfortunately the only place to grow the unit was a hospital that was not attached to our main hospital campus, had no ICU, no HDU, and the only medical staff after recovery closed were junior doctors in their first or second year out of medical school, so we had to be careful. There was also a lot of prejudice, and there still is a lot of prejudice in our government hospitals against medical and surgical treatment of obesity. And that comes with some real misconceptions around obesity surgery as being high risk, high stakes, dangerous, costly, etc. And it was high stakes for the unit, not so much for the patients, I guess, but with this prejudice, high rates of complications, emergency representations, a lot of transfers to the main campus probably would have put the program at risk and may have led to it being shut down. So we've all seen this sort of basic idea of ERAS, and often we look at that as some protocols to be made around the workup and intraoperative procedure and then care afterwards. But in the case of this unit, and I think this is an opportunity, is that a team was formed around each of these stages, and in fact to include the outpatient follow-up stage as well. And rather than the surgical team making these protocols, it was a group effort. And not only that, but the teams that make them are empowered to apply them in the way they see fit, and change them over time to make them better. And all members of the team have that power. Importantly, the teams are not a personal basis, but a role-based. And so we have a number of surgeons, a number of anaesthetists, a number of dietitians, etc. And there's enough people that if someone's on leave or not available or whatever, the team still functions very well. But the team's still small enough that we're concentrating experience over time. There's some consistency across all the stages. So the same anaesthetist, as Simon pointed out, the anaesthetist that sees and assesses the patient in the clinic is the one that's giving the anesthetic and is the one who's joining us in the multidisciplinary team meeting to discuss upcoming patients. And that comes with a lot of advantages, and it really should be routine, I think. And all of these people own the protocols and all are allowed to make suggestions and change them as they see fit. And the result of having a ERAS speaks for itself, and our results were no different to anyone else's. When you implement an ERAS, your unit can grow, the workup efficiency improves, and you can track that by looking at, say, the number of visits to the clinic a patient needs to have before surgery. You can track theatre time and see that your operations get quicker, and you can track length of stay and see that that gets better and more consistent over time as your ERAS is invented. So I guess my next question to the team is, who made your ERAS? Was it a single surgeon? Is it just the surgeons doing all the heavy lifting? Did you share that heavy lifting with your anaesthetists? Or have you included the whole multidisciplinary team? And this is an idea that occurred to me yesterday when I was listening to John Dixon was, we don't have a patient at all involved in designing our ERAS. And I wonder if anyone has a patient, and if you do, I want to talk to you. I want to know how that happened and how patients can influence the development of these, because we don't have that, and I think we should. Again, we touched on the idea of ERAS being a perioperative phase, but I think we're treating a chronic, progressive, recurring disease, and maybe we could look beyond the immediate perioperative period and see how the ideas of good teamwork, efficiency, and using effective protocols could make that more efficient, safer, and more effective as well. And again, we often start our ERAS protocol when we choose to do the operation, when we sign the patient up for that operation, or even wait then and only start our ERAS 2 weeks before with the VLED stage. And so I think Asim spoke to this very nicely. There's a lot we can do, and a lot we can do. The earlier we start, the more effective we're going to be. And I think don't forget the referral as part of the patient journey. That's our first set of information about that patient. And a standardized referral form is a really valuable tool. We use one, the patient and their GP fill it out together and send it in. And because that was designed by the whole team, the information on that form lets the anaesthetist know whether they'll need any further testing, whether they need to be seen in the clinic before operation. We know whether they can have their operation at the low acuity campus or they need a HDU backup. Our bariatric liaison nurse knows everything they need to know to guide that patient through the whole pathway from the moment they receive that referral. And they don't need to come to clinic if they're not eligible for surgery. And also by moving the selection, education, workup as early in the process as possible, starting it before the patient comes to clinic, then you really have a chance to maximize the benefit of that. I'm going to move on because I think I'm taking too long. These are the criteria we use to select patients for our low acuity campus, and we've really tested these over a few years and found that these are patients you can operate on, if you like, without a safety net and do very well. So we'll accept a BMI up to 56. If they're over 52, we do some extra testing to ensure their right heart function's okay and they don't have obesity hyperventilation syndrome. 48 for males. Males tend to be worse at a few things, and one of them is recovering from bariatric surgery. We'll accept any degree of severe sleep apnea, but they do need to be established on CPAP if it's moderate or severe. In fact, I think we've changed that now to just severe, but any three of those comorbidities. And we had a few select comorbidities that we're very careful on. So anyone that's on a chronic pain regime and has complicated pain issues, that can be very hard to manage without specialist support. Likewise, severe chronic kidney disease or moderate or severe respiratory, and that should also say cardiac disease as well. When we examine the outcomes of these, this is a very inclusive criteria. So the average BMI was 48. 48 is significantly higher than the average BMI in our whole Australian bariatric surgery registry. It's a higher average BMI than the IFSO registry. These are not small patients. You can operate on big patients here. A diabetes rate of 22%, nowhere near Simon's group, but that's double, again, almost double the Australian bariatric surgery registry's rate for diabetes. We have higher rates of OSA and other comorbidities than the average for our country, and yeah, a lot of patients with multiple complications. And the results for us were the unit could grow very rapidly because the resourcing required to do the operations was much less. And the main advantage was that we separated these patients from emergency surgery and cancer surgery, which wasn't happening at this facility, and that meant that we weren't competing with operating lists as we were in the main campus. And when we looked at the outcomes, it's a busy slide, but the simple answer is they were, as you would expect, similar to laparoscopic cholecystectomy, except the cholecystectomy patients were healthier patients to start with. The number of transfers were low, the number of complications were low, the need for high dependency unit, the need for reoperation were all consistent with what we all know in this room to be true, that this is safe surgery. Now, the next thing to point out, though, is these were our criteria when we published them just before COVID hit, but we've moved on from these and we've expanded them significantly. And so at the point that we're in now, BMI is less of a concern or worry to us. It's getting less and less relevant all the time. As I said, we're sort of less picky about the moderate sleep apnea now, and some of those patients with chronic kidney disease and respiratory or cardiac disease that we previously would have excluded, we're now doing. And the biggest change has been that we initially excluded revision patients from this facility, but now we're doing select revisions at this facility as well with good outcomes. And how that happened, I guess if I step back, we all know that surgical risk comes on a spectrum. There are a few patients very low risk, most patients are about average risk, and there's a few patients that are very high risk. And we're very used to, as surgeons, drawing a line when we say, no, this is too high risk, this patient is not safe for surgery. And as our techniques improve, that number of patients gets smaller. Our surgery gets safer and the number of patients we need to exclude gets smaller. What sounds a bit strange is the idea of declaring patients too low risk for a facility, for saying, no, you are not unsafe enough to have surgery here. You should go somewhere where the resourcing is less. It sounds a little bit strange, but actually we do it all the time. And again, as we get better at what we do, the number of patients we can say that to safely gets larger and larger with really positive effects on resources. Then, of course, there's the patients in the grey zone. We don't know, do they belong in the low acuity centre, the high acuity centre, or are they high risk or too high risk? And that's where the multidisciplinary meeting comes in. And so we take the patients out of the grey zone and decide where they belong. When we discuss our patients, though, we go a step further. Every time we discuss a patient, we look to get to the heart of what is the issue that we're discussing here and come to a consensus decision that doesn't just affect that patient, but changes our guidelines so that they now include that issue in the future. So we make a decision once, and all future patients that come with that same issue, that decision has already been made. That means over time, less and less patients in the grey zone, and a lower and lower proportion of our patients that need discussion, because our protocols are becoming more accurate over time. What we've noticed as a result is more and more patients are being moved into those lower risk categories. And what's really interesting to me is that it's not the surgeons driving that. It's not the surgeons forcing that. It's actually more the anaesthetists that are really driving that move towards more and more patients in this low acuity centre. They own these criteria. They're very proud of the ability to provide this surgery that otherwise the patients would be blocked from, and they're including more and more patients all the time. So I guess I'll finish up by restating what I said. I'd suggest that ERAS, if you use it as a basis for team formation and having empowered and engaged teams, then really the programs write themselves, and you don't have to worry about compliance, because if the team's already involved in writing the program, then they'll use it well. The second is, I think there's great opportunity in looking right back to the time of referral, maybe even before referral, and then looking out into the long distance care in terms of designing our protocols, And then we can use the MDM not just as a way to discuss clinical issues and individual patients, but it's a really good tool for renewing, adapting, and evolving your ERAS protocols over time to make them better and better. Thank you very much.
Thank you, Alex. Any question?
Dr. Craven, Daryl from Singapore. Thank you for a very good talk. The work you've done is amazing. I have two quick questions. One is, you mentioned that for patients with significant comorbidities, more than 3, you would exclude them from your program. Was this an arbitrary decision, or was there some evidence or some kind of scoring system behind it? My second question specifically is for patients with known cardiac disease. Where we practice, our anesthetists tend to send patients to HDUs when they have cardiac issues with a low EF, a depressed ejection fraction. So is this something that you face in your practice as well? Thank you.
Yeah, so I guess to your first question, it was really our anesthetic group that looked at the broader anesthetic literature around adverse events during surgery. And I think if they were here, what they would say is that that broader literature probably doesn't apply as well to the bariatric surgery population because they're younger, because a lot of their risk factors are actually modifiable by doing the surgery. And so that criteria, it was not arbitrary, it was based on some scoring systems more broadly used in the anesthetic literature. But I think it is another area of our criteria that is becoming less and less relevant. And so if people don't meet the criteria now, that normally means an MDM discussion to really think, well, probably we should operate on them. Number of comorbidities is a common reason for us to make an exception to a criteria and take them down the road. In terms of the cardiac comorbidities, that's is a bit of a problem. Those we don't have many with heart failure, and that is a pretty strong reason for the patients to go to the high acuity campus. The second issue around that is it's often hard in our very largest patients to get accurate appraisal of the cardiac function, particularly the right heart is not well seen on transthoracic echo. And so then do you do a TOE at the time of your gastroscopy, and these things need to be decided. So that patient population is not only difficult decision making, but also difficult assessment in the first place. And I don't have a good answer to you, I'm afraid.
Okay, thank you, Alex. The next speaker is Dr. Jiang Fan Zhu. He's from Shanghai, China. Because pandemic, he just a video. Play the video. This is another speaker.
And I'm Yan Gu from the Huadong Hospital, Fudan University, from Shanghai, China. And my topic is the Chinese expert consensus on ambulatory laparoscopic CV gastrectomy. And as we know, the obesity and overweight population increased rapidly all over the world. And the WHO data tell us that more than 650 million people in the world are in the obesity situation. And it's the same in China. And the recent data published in 2021 tell us that in China there are more than 50% of the population are in situation of the overweight and obesity situation. So in China, the obesity is also a very severe problem we have to deal with. And there are many different kinds of therapeutic ways we can do to deal with the obesity patients. And bariatric surgery is, of course, is a very important procedure we can take to treat the patients, the morbid obesity patients. And of course, there are many different kinds of procedures we can perform for the in bariatric surgery. And among these different kinds of procedures, the sleep gastrectomy become the top one procedure performed all over the world. In the United States, in 2013, the sleep gastrectomy surpassed RYGB and become the #1 procedure performed in the United States. And in 2019, the data showed us that in the United States, about 30% of the procedure was sleep gastrectomy. And also the same in China. In China, in 2015, the sleep gastrectomy surpassed RYGB and become the #1 procedure performed in China. And the data from 2021 tell us that in China, more than 8% of the bariatric procedures was the sleep gastrectomy. So the sleep gastrectomy become the most commonly performed procedures, bariatric procedures in the world. And next, I'd like to say something about ambulatory surgery. Of course, the typical ambulatory surgery is a surgical procedure performed that allows the patient to leave the facility in the same day. But in some other circumstances, in some different circumstances, for example, it's also depending on the law. In the United States, depending on state law, the patients in some states can be stay not only 24 hours, 4 hours, but also can be extended to 48 hours or even 72 hours. And that's also in China. In China, according to the China Ambulatory Surgical Association, the definition for the ambulatory surgery, the length of stay, of course, is the traditional is within the 48 hours. But for some special circumstances, for some complicated cases, it also the ambulatory surgery, the length of stay can be extended to 48 hours. So in China, the ambulatory surgery is okay for 24 hours and is also okay for 48 hours. They are all okay for the bariatrics, for the ambulatory surgery. How about the situation of the ambulatory bariatric surgery performed in the world? There are many papers published about to tell us the situation nowadays. And this is the paper published in 2018 in Thought, and tell us that in the United States, more than 50% of patients were discharged from the hospital within 48 hours. And this is another paper also from the MBS Equip Ambulatory Surgical Center guidelines tell us that in United States, more than about 93% of patients could be categorized as low risk and could potentially be done as the ambulatory bariatric surgery. And how about safety and effectiveness? There are also many investigations, many papers have tell us that the effectiveness and the safety for the bariatric surgery is okay. This paper is also from the MBS Equip and 10,000 ambulatory bariatric surgeries, and tell us that the patients undergoing laparoscopic RYGB or sleep gastrectomy procedures can be safely discharged on the day of their procedure without increased incidence of morbidity, reoperation, or readmission. And how about the situation of bariatric surgery in China? In China, the average BMI is not high. The average BMI is about 37.6. This is the data from 2019. But the length of stay after the operation is 5 days. So we can see, as compared to other countries in the IFSO data, we can see the level of the length of stay of China is in the low level. So in China, we have to do something to improve the quality of the bariatric surgery and shorten the length of stay after the bariatric surgery. And a group of Chinese bariatric surgeons established the Chinese expert consensus on ambulatory laparoscopic gastrectomy from 2019, and the consensus was published in this year, 2022, in this year. And CC Wang is also the president, and this consensus is also under the guidance of the CSMBS. And this consensus focuses on two parts. One is we established the indication for ambulatory laparoscopic sleep gastrectomy, and another part is about the management of the patient, how to manage the patients with ambulatory laparoscopic sleep gastrectomy. We first established a requirement for ambulatory laparoscopic gastrectomy. The facilities, the hospital should be the tertiary hospital, and the annual bariatric surgery should be more than 200 cases, and the surgeon should be senior attending surgeons at least or above, and the surgeon should be the experienced bariatric surgeons, and the number of bariatric surgery performed by the surgeon should be more than more than 50 cases. And all these items was approved by the more than 70% of the bariatric experts surgeons in China. And we established indication for ambulatory bariatric surgery. And in addition to the surgical indication established by the Chinese surgical treatment guidelines for the obesity and the diabetes patients, there's still some other requirements. For example, the age. The age should be, for ambulatory bariatric surgeries, should be between the 18 and 60. If the patient is too old or too young, it's not suitable for ambulatory bariatric surgery in Chinese consensus. And the preoperative BMI should be less or equal to 40, because the average BMI in China is less than 40, and it's about 37. So we established this criteria. And SA score should be less than 3, and patient comorbidity should be under control, and should have the MDT preoperative evaluation and some other items also established in this consensus. And also, of course, all these items was approved by the more than 70% of the Chinese expert bariatric surgeons. And there are still some contradictions for ambulatory bariatric surgery. For example, if the procedure is a kind of revision surgery, or the patient have the previous history of major abdominal surgery, or the patient is in poor condition, type 1 diabetes, severe anemia, severe ulcer, if the patient's the situation is not good, it's not suitable for the ambulatory bariatric surgeries. About the management of the ambulatory laparoscopic gastrectomy, we focus on 5 periods. The first stage is the preparation before the admission. This period is means the 2 to 4 weeks before the admission, and in this period we encourage people. We ask people to have the preoperative education, and encourage people stop smoking and alcohol intake, and encourage people weight loss, and do something for respiratory function exercise. And the second stage is the preoperative preparation period. That is 1 to 2 days before the surgery. And in this period, the food ingestion is allowed 6 hours before the operation, and oral ingestion of liquid 2 hours before the operation is also allowed. We don't use the routine mechanical ball preparation. And also, we do something, for example, the prevention of thrombosis and preventive use of antibiotics. And the third period is intraoperative management for the sleep gastrectomy. And the procedure should be performed minimally invasive surgery. For example, the laparoscopic surgery or the robotic surgery, and anesthesia should be general anesthesia. And we encourage less or no opioid-containing drugs, avoid CBC, and also we use we shall use the protective pulmonary ventilation to reduce the postoperative pulmonary complications, and fluid infusion is controlled, and we don't routine use the abdominal wall drainage. We don't routine use the urinary catheter and the gastric tube. And the fourth period is a post-operative management period. That is the period within the 48 hours after the operation. And what we do is the pain control, multimodal analgesia with non-opioid analgesics is encouraged, and early oral liquid intake 2 to 4 hours after the operation was encouraged, and the early activity 4 to 6 hours after the operation also is encouraged to reduce the risk of pulmonary embolism or venous thrombosis. And the last period is, of course, the discharge after the operation, the patient discharged from the ambulatory center. And we encourage the patient drink at least 1 to 1.5 liter of water every day, and communication with patients at least every 1 to 2 days within the first week. This is very important after the operation. And after the first week, we follow up closely 1 week later according to the clinical routine regulations. We established the discharge criteria for the ambulatory bariatric patients. The patient should be in good condition, and the pain is controllable, and no obvious nausea or vomiting, and resume the activities, and can voluntarily urination, and body temperature should be normal, and heart rate should be less than 100 per minute. If the patient did not meet these requirements, the patient cannot be discharged from the ambulatory center. And if the patient failure to meet the discharge requirements, or the time of the operation is longer than 3 hours, or there's some unexpected complication happen during the operation, the patient shall conversion from ambulatory center to the routine hospitalization. So in China, the ambulatory sleep-tracheotomy have been accepted by more and more surgeons, and I think there will be a good future for the ambulatory bariatric sleep-tracheotomy in China. Thank you. Thank you for your kind attention.
Dr. Ku, are you online? Will. Okay. Next speaker is Dr. Zhu. Dr. Zhu Jiangfan. Next speaker. To play. Yeah. Nothing online. Oh. Dr. Ku.
Hi, Professor CC Wang. I'm here. Is there anything I have to do? Is there any question I have to answer? Yeah.
Okay.
I'm waiting here. Yeah.
Hello.
Hi.
Hi.
Yeah. Hi.
Any question, Dr. Ku?
Yeah.
Online.
Yeah. I'd like to answer any questions from the floor.
Now, Dr. Sam, any question?
No question. Okay.
Hi, I'm Simon from Hong Kong. Just like to know your operation is doing in your ambulatory surgery center. So, so this center, is it affiliated or close to the main hospital, or is it a separate facility that in case of any problem can easily transfer?
Yeah. Thank you, Simon. In fact, in China, most of the ambulatory unit is affiliated to the hospital. In fact, most of this hospital is a tertiary hospital. So this is why in China, in fact, the ambulatory surgery, most of the hospital in China is a public hospital. It's not private hospital, not like the United States. United States, I think the ambulatory, most of the ambulatory is the private clinics. But in China, most of the ambulatory unit is affiliated to the tertiary hospital. So this is why I think we in China, in mainland China, we can do this kind of ambulatory bariatric surgeries. If there's anything happen, we have enough experienced doctors, enough the equipment, we can deal with it successfully. This is the one thing I want to say. And another thing I want to say is that for bariatric surgery, we have a strict criteria selection. If only the patients can meet the requirement of criteria, then we accepted kind of patients as the ambulatory patient. Otherwise, we will not perform the ambulatory surgery. And the third is that in China, there's the state of the length for the ambulatory surgery patients is within 48 hours, not like the traditional 24 hours. I think overnight is very important. Thank you, Simon.
Okay, thank you. Dr. Gu, Professor Gu.
Thank you.
Hope meet you next time face to face. Okay, the next speaker is Dr. Zhu, also from China, Shanghai. We play a video. Another one? No? Yes. Zhu Jianghuan. Presentation. Online presentation. Okay. We translate. Next, we invited Dr. Dong Ziyong, from China, from Guangzhou Jinan University, the first affiliate hospital. His topic is summary. Chinese board consensus on persist biological surgery. Okay.
Hello? Does it work? Oh, it works now. Hello, everybody. Good afternoon. I'm Dr. Zhiyuan Dong from the First Affiliated Hospital of Jinan University, China. I'm so glad and honored and pleased to be on behalf of CSMBS to report Chinese expert consensus on precision obesity medical surgery 2020 edition. So what is precision medicine? As we all know, in 2011, the concept of precision medicine was first reported in an article toward precision medicine released in U.S. National Medical Intelligence Report. And also in 2015, USA President Obama announced precision medicine initiate in State of the Union address. So the concept for precision medicine were defined as use advanced knowledge in molecular biology, genomic, and bioinformatics develop individual prevention and treatment program, and to target toward improving the effectiveness of treatment, reducing health care costs, and providing the best available care to each individual. So now, what's the precision obesity metabolic surgery? Actually, in 2014 to 2016, Professor C1 proposed the concept of precision RYGB and precision surgery for obesity in China. The precision RYGB is considered as a form of modern laparoscopic gastric bypass surgery that focuses on achieving a high level of precision planning and visualization and control with minimal invasive in its procedure. To achieve a high degree of organ protection and a good result on weight loss. So it sounds complicated. Effectively, the concept of precision surgery for obesity including two parts. One part is precision managed for bariatric surgery, and the second part is precision medicine, like gene therapy in the future. So in detail, precision diagnosis criteria and consider psychology treatment and review evidence-based medicine, adopt model, MDT model, and develop a precision anatomy and standard procedure, consider laser surgery and integrate management of the operation. Establish large clinical database and in the future precision general therapy. So these all detail belong to precision obesity metabolic surgery. So based on this background, CSMBS invite more than 100 domestic bariatric surgery surgeons to conduct 4 aspects regarding 36 questions Based on evidence and the vote, CSBS has formulated Chinese expert consensus on precision obese metabolic surgery, aiming to provide a guideline for the clinical practice of bariatric surgery in China, and in order to get good result. So the key point of this canton is sound like including all about talking in this concern. The part one is precision preoperative assessment. I'll go quickly because it's just in 10 minutes. It's about 4 questions and 4 recommendations regarding multi-dimensional measure of obesity and the evolution of obesity-related comorbidity and mental status, and assessment of nutrition status. The part 2 is about the precise preoperative management. Like just, it's about 4 questions and 4 recommendations. It's about how much weight should be lost before surgery. Just like Saint said, the low-calorie diet, and 2 to 4 weeks before surgery to be prepared. And prevention and treatment of OSAS or OHS. The part 3 is the most important one, precision surgical operation. Just like Simon said, the intraoperative secret. So the recommendation 9 is to follow up the bariatric surgery guideline and evidence. If the patient do not meet the indications, no surgical intervention is recommended first. Recommendation 10, the choice of surgical methods to be based on the relevant weight loss guideline, the patient's role, one situation, and the patient's will, the professional skill of the bariatric surgeon, and the patient's goal. And if for special case, especially for a reversion surgery patient, the evidence-based medicine and the MDT model should be conducted to make the decision, treatment plan. If the patient got GERD or hiatal hernia, the sleep plus hiatal hernia repair or sleep plus fundoplication or bypass to be performed. If obesity combined with moderate to severe GERD and obesity combined with type 2 diabetes, a patient who primary purpose to treatment type 2 diabetes to the hospital, and the super obese patient is all indications for RYGB. And there are some detail about the procedure. In every detail, recommended 15. Do not over pursue the short operation time, and do not over pursue a small number of tracker, and using absorbed material as much as possible, and try to completely stop any bleeding during the surgery. And we should pay attention to blood supply and the tensions in the anastomosis site. And the surgeon should be keep good mood and good health during the surgery. And we should choose a high quality laparoscopic system and equipment. Drainage tube should be not routine place to put in every case, but there are about 70% of experts don't agree that they think that drainage tube should be regular in every case in avoiding to leaking and bleeding. About sleeve gastrostomy, there are some recommendations, like about 2 to 6 from the pylori should start with stabilize, and 32 to 40 French bridges to be used to guide before the gastric incision. And we should place 1 centimeter away from an angle of his by the last shoot. And suturing the great augmental and the stabilize to be conduct, and the stabilize of stomach is reinforced to be performed. And for by gastric pass, the gastric pouch should be 10 to 30 mL value. And the small in the BP link will be 30 to 100 centimeter, but the 20 experts don't agree that. I don't know what the opinion. The 24 recommendation is about the total small ball should be measurement in every case when we're doing gas bypass. But there are 22% of experts don't agree with these questions. Recommended 25, the atmosphere between the stomach and the jejunal should be controlled at 1 to 1.3 centimeter. Peterson space and the mesocolic defect and the 12 males tracker should be closed. About the recommendation 26, retrocolic and thermosis should be used during bypass, but there are almost 50 experts don't agree that. They think that colic thermosis is better for thermosis during bypass. So the last one is part 4, precise post-operative measurement, also mentioned by Alex and Simon. They are regarding ELISA principle and liquid diet and like protein taken, nutrients taken. I should mention the recommended 34. PPI should be taken for at least 30 days after bariatric surgery. But there are 15% of experts don't agree with the question because they think don't need to take PPI regular after the surgery. If the patient have no stomach, no like symptom after the surgery. The recommended 35. The risk of gallstone increasing after the bariatric surgery. So also oxycolic acid should be taken at least 6 months after the bariatric surgery in order to prevent gallstone. But almost 34% experts don't agree with these questions because they think in Chinese the food style or type of food and the food in tract is different. So it's a few people get gallstone after surgery. The last one is about database. Database also is important, including medical history, every information, including imaging data, and the regular follow-up and experience is also important. It's important to achieve a long-term good result. So here is all about the concept of obesity and metabolic surgery. So in conclusion, the concept of obesity and metabolic surgery is a concept regarding precise management before surgery, during surgery, and after surgery. So that's all. Thank you for listening. If any advice, I will be appreciated. Thank you.
Thanks, Dr. Dong. Any question? Sam.
Thank you. Thank you very much for explaining the principle background of this precision surgery. But the term that you use of precision obesity surgery is a bit confusing because the first Obama or whatever precision medicine is talking about the genetic makeup or the genome of individual that we try to assess and modify and treat according to that. But what you are talking about is the precision in management. So it's more like a clinical pathway that a society suggests a surgeon to follow. So because when in Chinese maybe the similar concept, but in English, sometimes people will get confused if we put this term out. Okay. So I think in the future, if you want to make it in the Asia Pacific, we need to modify the terms a little bit. I think it will be better. But it's good to see it that at least we do have a Chinese guideline how to management on bariatric patient. I think this is a good start on this topic.
Okay, thank you. This paper just published last week in Chinese, so we're trying to get more advice and to update this consensus. I was asking you and email you. I'll finish the paper.
I also had a question. Sorry, I probably should know, but does China have a national registry that surgeons contribute to for these cases? And I guess, will there be a process for looking at revising this precision guideline as you go forward through that registry?
I mean, the international consensus, right?
Database, Chinese database.
So we all follow like database from PubMed, from RCT, and there are few database from Chinese article.
Oh, sorry, I meant a registry of patients. Do you have like the IFSO registry where all the patient data is collected for the country so that you can look at the whole system? Do you have an established database, and will you be able to use that to, I guess, look and see whether these very good guidelines could become even better?
So thank you. It's a good idea and good suggestion. We do have a like Chinese database. We have two largest database in China, and now the publication from the database is becoming more and more. So it's a good idea. We all put some data and evidence from there. So thank you.
Good idea. Thank you. The next speaker is, thank you, Dr. Dong. Dr. Zhu, he have a video, but the video is maybe not finished. We can play it one by one. Okay. Alex, I have a question. In Australia, if the patient earlier discharge, go home, maybe the patient may be like it. If this hospital, maybe after sleep gradually just need 1 day, another 3 day, 4 day, maybe patient like 1 day the hospital.
Yes, certainly because we have two systems, the public system and the private system. In the public system, it is a big advantage for the patient to go home early, for the hospital and for the patient as well. In our service, without having a deliberate pathway, about 10% of our patients will go home after 1 night in hospital because they want to, and because they are ready. And we are looking at creating a deliberate pathway to increase that number, but at the moment, by accident, we have about 10%. In the private hospital system also, I don't know what the numbers are, but also there is strong support from the private hospitals for ERAS because they know that they spend less money per patient, and the way the private hospitals make money is similar. And I think most of us feel that when patients are home, they move more, they're naturally more active, and our feeling is that the patients that go home earlier actually are much more happy with their care.
Okay, thank you. That's good. Can we play?
Hello, Dr. Wang. Can you see my video presentation? I'm share. Hello.
Zoom meeting. Zoom meeting, but he not in home. He told me maybe he in room. He maybe can't.
Hello. Hello, Dr. Wang.
共享，他写的，he play, Zim.
Hello.
Play Zim.
Hello. Hello, Dr. Wang.
Oh, okay.
Okay. Can. Okay, I saw on the screen. Can I begin?
주? 다들 주?
Yeah. Can you hear me? Can you say share my presentation?
예, 예.
Okay.
Having trouble connecting to the audio for the Zoom meeting. We will figure this out.
No. How much we? I can. Okay.
Is it okay for you?
Yeah, he's playing.
He's playing his presentation, however, the audio is not yet connected. He's not yet connected to our
No voice.
Is it okay if we play his presentation for him on behalf of him instead?
我要再共享一次，我把这个断开试试看看。
Okay.
现在有声音吗？能看到，我看到那个屏幕上有我的幻灯的。
Audio. Okay.
现在能看到了，我要从头再放一遍吗？I'm so sorry that I'm not available for this important congress for COVID-19 pandemic. 现在有声音了吗？ Is to introduce our newly published consensus. Chinese expert. 好的，就是没有从头开始。On enhanced recovery after surgery in bariatric and metabolic surgery by using a modified therapy approach. This consensus was conducted by Chinese Society of Diabetes and Bariatric Surgery, Chinese Association of Research Hospitals. Look at the patient in the operating room after laparoscopic symplectomy surgery. The present technique made rapid recovery after surgery possible. In 1997, Danish doctor Carlite proposed the concept of promoting rapid recovery based on the progress in clinical researches. Now the ERAS principle is widely applied in various fields of surgery. The ERAS principle is widely applied in various fields of surgery. In fact, the ERAS principle is more important in bariatric surgery. Chinese expert consensus on ERAS principle in bariatric surgery was set up by using a modified Delphi method. The consensus was established based on the Delphi approach. As we know, the traditional approaches to consensus building is composed of writing by different authors and panel discussion. Such a consensus cannot represent the opinions of most experts. Delphi approach was established by Dake and Hammer in 1950s, which include question design and voting. The method is now a universal approach to building expert consensus in the field of biology. To build the consensus, we invited 20 famous experts in bariatric surgery to organize the expert panel. The task of the panel was to submit the reviews, the entries, participate in the voting, and review consensus documents. Physicians with over 50 cases laparoscopic bariatric surgery experience were invited to vote. 56 bariatric surgeons and 20 experts were invited to vote. 41 ERAS entries were introduced into Survey Monkey app in the mobile phone. The approval rate in 14 entries was larger than 80% in first round voting, which were arranged into the second round voting. Entries with approval rates larger than 70%, which were considered no, after 2 rounds were considered consensus. The approval rate for 6 items was less than 70%, which were considered no consensus was reached. They also completed the consensus document according to the voting results. The consensus was sent for publication after review by the panel. The consensus include pre, intro, and post-operative management for the bariatric surgery patients. The purpose for the ERAS consensus is to higher patient satisfaction, rapid patient turnover, healthcare economic growth, and decrease complication rates. Table 1 is the ERAS principle before bariatric surgery, which include fully communication with patients, improve obesity-related diseases, rapid recovery, drinking or eating after bariatric surgery, and pre-operative prevention of surgical complication approaches. The item night fasting should be avoided, and a clear lower diet should be encouraged 2 hours before surgery was not reached consensus. In fact, this opinion is now widely accepted in the world. Chinese colleagues are still worried about anesthesia aspiration. Table 2 is the ERAS principle during bariatric surgery, which include which surgical method is favorable to ERAS principle, such as laparoscopic, single port, and robotic surgery, medications in anesthesia and testers, and so on. Single port or robotic surgery was not reached the consensus for the ERAS principle. The item is not placed intraoperatively was not reached the consensus. The drainage is very important for discovery or prevention of post-operative complications. items after surgery include postoperative pain, POLA management, diabetes prevention, early drinking or eating after surgery. The item clear diet was studied 2 hours before surgery was not reached the consensus. The Chinese colleagues are still worried about the patients cannot tolerate early eating. The most interesting is that the item discharged the next day after bariatric surgery not reached consensus. The daily hospital charge is very cheap in our hospital, so it's not necessary for patients early leaving the hospital. The patient need 2 or 3 days fluid infusion to provide their daily necessary fluid. Items not paid for ERAS reached consensus, which include aged patients incapable of looking after themselves, complicated surgeries, severe OSA or severe POLA, and severe mental or psychiatric illness. Thank you very much for attention.
Thank you, Dr. Zhu. Any question? Okay, no question. Thank you, Dr. Zhu.
Yes.
Offline. So this session, we finished the guideline. Thanks everyone. The lessons. How many lessons?
Okay.
Alex. Alex. Which one? Sub high tech. This same.
And Dr.
Alex. Dong. Congratulations. Thank you. Take care. Thank you, everyone. See you.
Hello, Dr. Wayang.
Hello.
Good afternoon.
Good afternoon.
How are you? We can probably start at exactly 3 p.m.
Yeah, sure. How about the other chair?
Michelle's also here.
Okay.
Yes, I'm Dr. Salonga.
Oh, Dr. Salonga, how are you? You are also from Philippines, or?
Yes.
That's great.
I wish we were able to come here.
Yeah, but we need a very long quarantine period here.
Oh, well,
10
probably.
days.
Oh, when you get back, you have to be quarantined for 10 days?
Yeah, at least 10 days. If you tested positive, it will be much longer.
Oh, next year we'll be in China, huh?
Yes, hopefully it will be fully open next year. So you can join us here in China.
Renu and Michelle.
Okay.
Renu and Michelle, yes.
Okay. Mr. Ryan, one of our children online and Zoom. We would like to see all of you.
Okay, sure. Where is he?
Hi.
Hi, Renu.
Wish you
look so
could have been here.
you look so casual. Are you going somewhere else?
No, I'm in a proper dress, full length dress, not above knee. Don't worry.
Okay.
Okay, so what are we gonna do?
We can probably start at...
So we have to sit here?
No.
And we'll sit.
You can sit at the table.
Okay, and the presenters are they online? Can we speak to them or they cannot? Are they
Yes, some
on?
of the presenters are online on our Zoom, and that
Okay.
they already gave us their pre-recorded video.
So they will play the pre-recorded and then can we ask them questions or? Okay, wait. Okay, wow.
Hey, but
Some of them are online, so we can ask them questions.
As I see, just one or two.
Yeah,
Hi,
one or two.
Michelle.
You are MIA.
We're missing you.
You are missing in action. You're supposed to be here. You just
Yeah.
got the news.
Okay, let's do this. Okay.
We can probably start.
Here's your microphone.
Dr. Wayang. Nothing.
Hi, Dr. Wayang. Your co-chairs will start the program in a while.
Okay.
Okay.
Respected Chairman and distinguished guests, good afternoon. My name is Chen Guanyang. I come from Beijing, China. Currently, I am pursuing my PhD at Peking University, and my PhD supervisor is Professor Zhang Mo. Today, I'm going to share a study entitled Establishment of a Nomogram based on inflammation-related methylation sites in intraoperative visceral adipose tissue to predict EWL descent after LFG. I will illustrate my study through the 5 points below, including part 1,
Sir, Dr. Wayang would
and
like to
introduction.
be please.
Part 2,
Nakita po kayo.
objective. Part 3,
Pardon?
methods. Part
Hello?
4, results. And part 5, conclusion. Part 1, background and introduction. LFG is considered an effective therapeutic surgery for patients with morbid obesity.
Okay.
Chronic low-grade inflammation of adipose tissue is associated with obesity and obesity-related complications. Part 2, objectives. This study proposed to establish a nomogram based on inflammation-related mesenchymal size in intraoperative visceral adipose tissue to predict EWF% at 1 year after LSG. Part 3, methods of our study. Based on EWF% at 1 year after LSG, patients were divided into 2 groups. The success group, group A, EWF% no less than 50%, and the failure group, group A, EWF% less than 50%. Next, we define genes corresponding to the methylation size in the 850 kilometer methylation microarray as methylation-related genes. Then, we took the intersection of MRGs and inflammation-related genes. After that, inflammation-related methylation sites were identified based on overlapping genes. Moreover, different analysis was carried out to obtain inflammation-related differentially methylated sites between group A and group A. Last analysis was utilized to identify half methylation sites. Finally, we developed a nomogram based on half methylation size to predict 1 year EWF% after LSG. Part 4, the results of our study. The most significant result of our study is a nomogram. We identified 3 half methylation sites, including CG03, 610073, CG03, 208951, and CG18746357 by lateral analysis and built a predictive nomogram. The area under the curve value of the nomogram was 0.953. Part 5, conclusion. The predictive nomogram based on 3 inflammatory-related methylation sites in intraoperative visceral adipose tissue can predict 1 year EWL% after LSG effectively. That's all. Thanks for your listening, and your comment is highly appreciated.
Is the patient online?
No, ma'am.
He's not online?
He's not.
Okay, so
Shall we
maybe
proceed
can
and then
move on?
Yes, we can proceed.
Before that, I'd just like to thank anybody in the audience who's young IFSO APC. Are you the only one? No, your staff? Okay, all right. So our Young IFSO APC session is going to be held virtually because of the visa restriction and the travel restriction still imposed in many countries. But thank you to everyone who is online with us today. Thank you to Dr. Wah also and my fellow co-moderators. So we'll proceed without further ado to the next video. If we can play the next video.
Thank you, Professor. I'm Qin Deng from West China Hospital. I'm honored to be invited to do this presentation. The topic of my presentation is the evolution of non-invasive methods for the detection of fibrosis in Chinese patients with obesity and non-alcoholic fatty liver disease. Non-alcoholic fatty liver disease is the most common chronic liver disease in the world, and liver fibrosis has been proven to be associated with liver disease-related events and total mortality. several invasive methods have been developed just like this picture. But whether those methods are suitable for the detection of fibrosis in Chinese patients with obesity and nephro hasn't been completely elucidated. A retrospective study consisted of 100 obesity patients who underwent laparoscopic bariatric surgery with nephro. We find white and amino transferers were independent risk factors for liver fibrosis. The share wave elastography API and modified API had statistical significance in predicting significant fibrosis in obesity patients with nephro, and both the share wave elastography and API had a significantly larger area other receiver operator characteristics than other methods for the detection of advanced fibrosis. In conclusion, white and linear amino transferers are independent risk factors for liver fibrosis progression in nephro patients. The share wave elastography and API had a predictive value for significant and advanced fibrosis of nephro in Chinese patients with obesity. Nevertheless, there are some limitations. The retrospective nature of that and the sample of the study is small, and the distribution of patients with different states of fibrosis is uneven. In the end, welcome to our Chengdu, China to see pattern and eat hot pot.
So should we go for the next one?
Dr. Wah,
Yes.
are you online?
Yes. I can see
Can we
you.
hear him? Hi, Dr. Wah. Dr. Wah, is it okay with you if we proceed with the two speakers who are online with us? Because we're not able to ask questions to the other presenters.
Let me try.
Dr. Lee, Zihong, nomogram, and Dr. Zhao for efficacy analysis of 4 different bariatric surgeries.
Yes, I think it is number 4, Dr. Lee.
Yes, number 4 and number 8, 9, is it 10? Yeah, 9.
Yes, 9. I'm not sure if they are online.
They are online. They are. So we'll proceed with 2 of them.
Okay.
Okay, all right. So can you play number 4? And just alert the speaker that we're going to start with his talk. Yes, thank you.
Thank you, Prof.
Good afternoon, honorable judges, distinguished guests, ladies and gentlemen. My name is Li Zehong. My PhD supervisor is Zhang Nengwei. I'm from Department of General Surgery, Beijing Sijitang Hospital, Capital Medical University. I'm extremely honored to have the opportunity to stand here and make a speech. Today, I'm going to look into this question with you. A nomogram based on adipogenesis-related methylation sites in intraoperative visceral fat to predict EWL% at 1 year following laparoscopic sleeve gastrectomy. I will illustrate my argument through the 5 points below, including Part 1, background and introduction, Part 2, objectives, Part 3, methods, Part 4, results, and Part 5, conclusion. Firstly, Part 1, background and introduction of the study. LSG is a crucial surgical procedure for morbidly obese patients. There is a strong correlation between obesity and expression of adipogenesis-related genes. However, studies on prediction of 1 year EWL% after LSG from adipogenesis-related methylation sites are still lacking. Part 2, objectives of the study. This work aimed to develop a model to predict 1 year EWL% following LSG in morbidly obese Chinese by examining the DNA methylation profiles of intraoperative visceral fat. Part 3, methods of our study. Firstly, we classify patients as either the success group or failure group, depending on whether their EWL% was 50% or higher at 1 year following LSG. After that, we analyze differentially methylated sites between the success group and the failure group. Differentially methylated sites were made to the corresponding differentially methylated genes. Then, we took the intersection of adipogenesis-related genes and differentially methylated genes, and we obtained adipogenesis-related differential methylated sites. Next, half methylation sites were identified by lasso analysis. Finally, a nomogram was developed to predict EWL% of morbidly obese Chinese at 1 year following LSG. Part 4, the results of our study. The most significant results of our study is the nomogram. The results are shown in the picture. The 4 half methylation sites were CG 0609 3355, CG 0029 4552, CG 0075 3924, and CG 1709 2065. Part 5, conclusion. The predict nomogram based on methylation size can predict EWL% at 1 year following LSG in morbidly obese Chinese efficiently, followed close by reference to the imaging from the debriefing process. That's all. Thanks for your listening.
Dr. Lee is online, right?
Hi.
Sorry?
I'm not sure if Dr. Lee
Hi,
is
Dr.
online.
Lee. Are you online with us? Is he online?
His name is online.
Yeah, can we hear his voice?
No, I cannot hear.
He's on mute? Okay. Wow, were you a part of these studies by any chance? Is this from your university?
No, it's from a university in Beijing.
Okay.
Maybe we move to the next
Because
one.
we just wanted to ask him what's the difference between his study and that of his colleague, the first paper.
Yeah, it seems that they are from the same team.
Is it the two same exact presentation or?
No, no, no. They are from the same team.
So what is the difference between the two papers?
Maybe we move to
We ask him after this when he's online.
Yeah.
Yeah. Okay, we'll go to presenter number 9. No, we'll do the next one who is online. He's online? He's online? Number 5 is Tao Jiang? No. Number 5 is not. Which paper? Sure.
Number 9 is online.
The video?
But-
Or you want to do that now? You don't want to do that after this? We'll finish, because he's already online, right? So we'll finish the paper first. Yeah, we'll do him and then we'll do the video. I think there was a video presentation which didn't make it for the morning session. So
Yes.
we'll also include that video after we finish the next paper.
Yeah, no
Is
problem.
that okay with you?
Yeah,
Okay.
no problem. I think Dr. Zhang Zheng is online.
Yeah, number 9, presenter number 9. Yeah.
Distinguished President, ladies and gentlemen, good afternoon. I'm Zhang Zheng, come from China-Japan Union Hospital of Jilin University, China. I'm very honored to give this speech at this conference. Today, I want to talk about some of our work in the field of super obesity among Chinese people. My abstract is entitled Efficacy Analysis of 4 different bariatric surgeries in the treatment of Chinese patients with super obesity. Firstly, I would like to introduce the background of my speech. It's well known that obesity is divided into several grades based on body mass index. Super obesity is BMI greater than or equal to 50 kilograms per square meter. Today, we are going to be talking about super obese people. Bariatric surgery is the most effective and durable therapy of obesity, and it also helps with the improvement of metabolic disorders. However, studies on bariatric surgery is the treatment of patients with super obesity are limited, especially in Chinese patients. So our research seems very necessary. This was the first study to report the outcomes of 4 different bariatric surgeries in the treatment of Chinese patients with super obesity. Our approach was retrospective analysis of patients with BMI greater than or equal to 50 kilograms per square meter who underwent sleep, RYGB, BPDDS studies at our institution between 2015 and 2021. As we can see, the mean preoperative weight of these 40 patients was 159.16 kilograms, and the mean BMI was 53.37. The preoperative body weight and BMI didn't exist statistical differences among the 4 groups. I will focus on this research and the development of changes in body weight and BMI at 1 year after surgery. As we can see from this chart, at 1 year post-operatively, BMI decreased significantly by 21 kilograms per square meter in sleeve and 15.9 kilograms per square meter in RIGB. In the same way, BMI decreased significantly by 25.3 kilograms per square meter in BPDDS and 23.6 kilograms per square meter in CIDs. what this graph shows is changes of excess white loss in the sleeve, RGB, BPD, and the CIDs. The next one is changes of total white loss in 4 types of surgeries. As we can be seen from the above two statistical charts, in terms of white loss, the most effective operation was BPD, followed by CIDs, sleeve, and RYGB. Of note, there was no significant difference between BPD and CIDs in terms of exercise white loss and total white loss at 1 year after surgery. 4 types of surgeries also include significantly obesity-related metabolic disease. But we didn't compare the remission rate of metabolic disease caused by these 4 procedures due to small sample size of metabolic diseases in age group. Now, I would like to sum up the result of this investigation. Sleeve, RIGB, BPD, and CIDs are effective for Chinese patients with super obesity in terms of weight loss and the remission of metabolic disease. However, BPD together with CIDs are the most effective operation in terms of weight loss, while RIGB is the poorest. Thank you for your listening.
Thank you, Dr. Zhang. I think Dr. Zhang is online. Is it?
Yes.
Hello, Dr. Zhang. Maybe you can turn on your video so that we could put a face to the name. 可以开 video 吗？你好。
Hello.
You can speak Chinese, man.
Yes, I can speak Chinese for his convenience. Okay, but for the interest of my co-chairs, I will speak in English. So you have a very nice paper. Congratulations on that. However, we have several questions. Were the procedures standardized across all of these patients? Were these procedures done by one single surgeon or several surgeons? And did you follow a specific protocol? 好像你们做的开刀都是一样吗？每个病人你开的刀都是一样吗？好像你的bypass 都是一样吗？
不是的。
He said, well, maybe you can translate. What I mean to say is that for each of the subjects who underwent RYG, gastric bypass, and those who underwent SADIs and the BPBD, did you perform the procedures exactly the same? Were the length of the limbs that were bypassed the same for each of these groups?
No.
Well, would you be able to help?
For pressures bypassed is not.
我的意思就是说，你做了胃道绕的，好像胃道绕的手术，你开的全部的病人开了胃道绕的手术，他们都的 bypass 的length BP length 都是一样吗？或是不一样？
就它小肠框制的长度是一样的吗？
都是一样的。
They're the same.
The same.
是一个医生做的吗？
Yes.
是说几个这种they are from a single surgeon.
Yeah.
Okay, 因为我们看过比较奇怪的，就是你的开胃道绕的手术跟胃道勺的手术看起来你们做的 sleeve gastrectomy 有比较好，对不对？可是你们全部的 BMI 都是一样吗？大家都是 BMI 52what's the BMI？Average BMI 都是53，都是53吗？我是有别的比较高，有别的比较好像50块，他们的 BMI 的 P value 都是不是 significant 吗
？BMI 都是大于50的。BMI 的BMI。
Wow, I'm so sorry. My Chinese is very bad.
Oh, I thought you understand. all the BMI. Sorry, Michelle.
Okay.
All the BMIs are over 15 because they are doing the super obesity patient.
Dr. Zhang, very good paper. Congratulations. Just this is not a question, but this is just to share maybe an opinion. So we see the same outcome in Malaysia, but of course we didn't do a study looking at BPDDS and also SADI. We compared sleeve and bypass in super obese, and we noticed that the weight loss at 1 year was more with the sleeve category versus the RYGB. So I didn't understand why that was the case also, but I absolutely understand how BPDDS and SADI can be a lot more because that's more malabsorptive, right, Wa? So if you're going to do something malabsorptive for a super obese, you might as well go all out. Don't be in the middle with an RYGB. Is that the take home?
Yeah, but they didn't compare the other results. They only compared the weight loss.
Yeah, weight only,
yeah.
not diabetes, not anything else. If you're only looking at weight.
Usually, BPDS maybe have better weight loss, but we worry about the nutritional issue after the surgery.
Yes.
So I think in Dr. Zhang's center, they are doing quite well for these 4 procedures. They are also doing robotic surgery for some super obese patients. But my opinion is that maybe we can, if we want to really compare the different types of surgery, their efficacy or the results, we may conduct 1 or 2 RCT. The randomized control trial will be great.
Yeah. And looking at nutrition as well, vitamin deficiencies and protein energy malnutrition.
Yes, maybe you
especially
can
ask in Asian culture, where we don't eat steaks the size that they eat in the Western world.
Yes.
Yeah. Okay. Is there any more questions?
Michelle, you can speak Chinese actually.
You can invite her for the next CSMVS.
OK， 谢谢你。你还有话要加说吗？
没有 ，thanks。
谢谢。
OK， 谢谢你哦。
So are we going to play another video from Dr. Tao Jiang?
So we're gonna do your paper first because you're online, so we will put you in the hot seat.
Okay.
Paper number 10.
I think Dr. Zhu is online.
Yes.
Okay.
Yeah, but we like disturbing you, so we'll also ask you questions.
Okay.
Good afternoon, everyone. It's my honor to be here share you our study. My name is Zhu Jie. I just graduated from Jinan University, and now I work at the Second People's Hospital of Yibin City, which is famous for its wine. My report title is Effect of Preoperative Proton Pump Inhibitors on Postoperative Nausea and Vomiting of Sleeve Gastrectomy. It's a randomized controlled trial from Jinan University. I'm breaking it down into 5 parts. To start off, we can see in the background that The incidence of PONV is as high as 20 to 80% in high-risk patients, and it can up to 90% in bariatric surgery patients. The consensus guidelines for the management of PONV are recommended taking 2 or 3 prophylactic antiemetics at the end of surgery at present. Some studies found that PPI may play a role in PONV by reducing basal and post-stimulated gastric acid secretion. So the purpose of this study is to explore the effect of preoperative PPI on PONV in patients undergoing laparoscopic sleeve gastrectomy. Participants with informed consent were divided into 2 groups randomly. Patients in treatment group were the number 1 group. They received PPI continuous for 1 week before surgery, while the control part was the number 2 group. They didn't receive any special treatment. We used visual analog scale to evaluate the pain and PONV in 7 different time points post-operative. We also assessed the severity of PONV by the simplified PONV impact scale. We mainly collected the pain and PONV score and rating in 7 different time points post-operative. We also collected the frequency, type, and time of post-operative rescue medications they used. We divided the 7 time points into 3 stages according to previous study in order to analyze and compare. The early stage was within 6 hours post-operative, and the late stage was 36 to 48 hours post-operative. These were the statistical methods we used. After assessing and randomization, there were 36 patients in each group. The demographic characteristic, medical history, and complications were not statistically significant. We found that the VAS for nausea and vomiting was lower in treatment group at all time points, and the simplified PONV score was lower except the 12 time point post-operative. The VAS for pain was lower in number 1 group in the middle and late stage. The incidence of PONV in middle stage of 2 groups were 52% and 80% respectively. The difference was statistically significant. The late stage of PONV were 5% versus 25%. The severity comparison of PONV showed that the incidence of mild, moderate, and severe PONV in number 1 group was lower than that in number 2 group. They were statistically significant in frequency of using antiemetics and analgesics between 2 groups. The number of antiemetics used in number 1 group was 0.8 lower than number 2 group. At last, we draw the conclusion that short-term using PPI before laparoscopic sleeve gastrectomy can reduce the incidence and severity of PONV, reduce the rescue medications. But due to these results were from our single center, we hope that more centers to participate in. If you are interested in it, you can contact me in this email. That's all. Thank you.
This is a very good study, very simple to do. Wow, maybe you might get some interest here if you want to continue with the study, because the cost is only what, 1 week of PPI?
I think Dr. Zhu is here. Yeah.
Yeah, Dr.
Good
Dr.
afternoon,
G is here.
everyone.
Good afternoon, Dr. G. Thank you for being with us.
Thank
Do
you.
you have
Thank
plans
you.
to continue
Nice
with the
to meet
study?
you. Sorry, what did you see?
Do you have plans to extend the invitation to more countries if they're interested?
Yeah, we want to more centers to participate in this study. We can further reduce the dose of PPI or shorten the time of the PPI the patients take. So we want to do
3 days?
more. Yeah,
You think 3 days is sufficient?
maybe we can try it in the future study.
Okay. What made you choose 1 week? Why specifically 1 week?
Because the consensus for the PPI use in the medical therapy for the cancer patients is recommended for 1 week. Is recommended to PPI to reduce the PONV for 1 week. They took PPI for oral and for sorry,
You can say it in Chinese. Michelle can translate for us. Don't worry. We have a translator.
OK，
他就是问为什么你们觉得要给 PPI 只有1个礼拜？为什么不是3天、5天？为什么1个礼拜？
是因为我们有一个中国的一个 PPI 预防化疗的恶心呕吐的一个指南当中指出是可以使用口服的 PPI 或者是一个静脉的使用 PPI 来预防化疗所导致的一个恶心呕吐。他们那个指南当中提到的是可以使用1个周的时间，所以说我们想把这个1个周的疗程把它放到我们的减重手术患者当中，看能不能有所效果。
不好意思，你讲的太快了，我的中文不是太好。
I'm sorry。
可是我了解的。对啊，yes。Okay, what basically I got is that I think they're following a certain protocol for oncologic protocol for prevention of gastric cancer that provides 1 week of PPI. Was that correct, Wa?
It is from chemotherapy guidelines. They recommend 1 week for the PPI.
Okay.
Yeah.
Maybe we can consider 3 days. Since we're not going on a physiological reason and more of a guidelines that is there, maybe we can even look at 3 days, 72 days.
Okay.
Right?
Yeah.
Okay, thank you so much. Oh, hold on, one more question.
Did you also exclude patients who already had previous PPI treatment? For example, on EGD, you find gastritis, or they were previously treated with PPI. They were excluded from the study?
Maybe some patients, what he means is some patients in the past may have had gastritis. So in those patients, if they were treated with PPI, were they also included in the study or were they excluded?
We didn't query
that history.
Yeah, all the patients have included in the study.
他就是问你的 paper 的病人，大家都是有没有以前的时候有没有吃 PPI？ 如果他们有吃了 PPI 的时候的话，他们也是在你的 paper 吗？或是在不要他们就是not included， 不要加在 paper 了。
We didn't query whether they take PPI before they included in the study. So or maybe some patients.
所以他们吃 PPI 没关系，以前的时候有吃 PPI 没关系。我的意思是说，他以前有吃 PPI。
Maybe let me translate. I think both of you don't understand each other.
不好 好意思哦。
朱姐，她问就是说，以前有就是接受过 PPI 治疗的，像那种胃炎啊那个什么的，那些病人有没有排除掉？
就是我们没有去就是询问他们进一步的病史是以前是不是使用过 PPI。
没有问这个是吧？
对对对，我们没有管他这一方面。
Okay. So I think you understand that, right, Renu? They didn't ask the history of PPI use or treatment, so they include all the patients.
Even in Malaysia, if we're going to do this study, I would say 90% of Malaysian patients would have been on PPI at some point. Everybody has gastritis. Our food is so spicy, it's crazy. Okay, so we'll move on to the next. Sorry, same with you.
In Dr. Zhu's hometown, maybe.
In Dr. Ju's hometown. Okay. Thank you, Dr. Ju. It was a really nice presentation, and you'll definitely have a lot of people interested in working with you.
Okay.
Congratulations.
Thank you.
So we'll move on to the next.
谢谢朱姐。
好，谢谢华哥。
They're all online? Okay, then we'll proceed. Yes.
Respected General Assembly President, distinguished judges, distinguished guests, good afternoon, everyone. It is a great honor for me to attend this grand conference. My name is Wang Zheng, from Surgery Center of Diabetes Matters, Capital Medical University, affiliated Beijing Shijitan Hospital, Beijing, China. My master degree supervisor is Zhang Nongwei. Today, the title of my speech is An Assessment of the Effect of Bariatric Surgery on Cardiovascular Disease Risk in the Chinese using CVD risk model. These are 5 parts of my presentation, which are background and introduction, objectives, method, result, and conclusion. Firstly, part 1. Many studies have reported that bariatric surgery may reduce post-operative cardiovascular risk in morbidly obese patients. But few have addressed this risk in the Chinese population. So, to assess the impact of bariatric surgery on cardiovascular disease risk in the Chinese population using the World Health Organization risk model, the global risk model, and the Framingham risk model. Then, we collected patients' information at our hospital and used the 3 risk model to calculate the change in cardiovascular risk before and after surgery, followed by statistical analysis in 2 subgroups, men and women, BMI greater than or equal to 35 square meters per kilogram, and BMI less than 35 square meter per kilogram. The results show that among the 61 patients, 26 had sleeve gastrectomy surgery, and 35 have Roux-en-Y gastric bypass surgery. Of the patients with BMI greater than or equal to 35 square meters per kilogram, 66.67% elevate SG, while 17.2.97% with BMI less than square meters per kilogram elevate RYGB. HDL level was significantly higher at 12 months post-operatively relative to baseline. The 1-year CVD risk after surgery will reduce a lot compared with the preoperative period. Finally,
by the above studies to conclude morbidly obese patients had a significantly lower CVD risk after bariatric surgery. This study also demonstrates that the models are reliable clinical tools for assessing the impact of bariatric surgery on CVD risk in the Chinese population. This is the end of my speech. And finally, I wish you all a memorable and a prophetic appearance here. Thank you for your listening.
Okay. Hi, this is Dr. Where are we? Here. No, this was we're done.
Wang Zheng.
Dr. Wang Zheng. Okay. Dr. Wang Zheng, are you online with us? Is Dr. Wang online? Can you switch on your camera so we can have a look at you while we talk? No, he's not with us. He's online.
He was there just now.
Oh.
Wang Zheng.
Maybe technical problem. Okay, we'll come back to him. So we'll go to the next speaker. He's online, right? The speaker is online? Okay.
Distinguished chairs and co-chairs, good afternoon. It's my great honor and pleasure to share my research at this meeting. I am Yu Chengyuan, a postgraduate student from the Surgery Center of Diabetes Mellitus at Peking University Ninth School of Clinical Medicine in China, with Dr. Zhang Nongwei as my tutor. Obesity and Metabolism Center of Beijing Shitan Hospital is the first independent center for bariatric and metabolic surgery in China. It has been 17 years since the center started laparoscopic treatment of obesity and metabolic diseases in 2005 and has so far performed over 2,000 bariatric and metabolic surgeries, and is one of the few hospitals in China that can perform all bariatric procedures. Today, my report will focus on the comparison of various prediction models of type 2 diabetes mellitus in Chinese population 5 years after ASG. The effect of bariatric surgery on type 2 diabetes mellitus control can be assessed based on predictive models of type 2 diabetes mellitus remission. Various prediction models of type 2 diabetes mellitus remission have been externally verified internationally. However, long-term validated results after ASG surgery are lacking. The best model for the Chinese population is also unknown. Aim of this study is to evaluate the prediction effects of various prediction models on the long-term diabetes remission after ASG in the Chinese population, and to provide reference for clinical use. To be specific, here are the methods of my research. First, we retrospectively analyze the data of Chinese who are 5 years after ASG and externally validated 11 predictive models to evaluate the predictive effect of each model on long-term type 2 diabetes mellitus remission after ASG. Inclusion criteria and exclusion criteria are as follows. According to the diabetes remission standard formulated by the American Diabetic Association, partial remission, complete remission, and long-term remission are defined as follows. We conducted a comprehensive search of existing models and excluded those that did not fit our study. Finally, here are the results. We enrolled 108 patients. Here is the baseline data. The 5-year post-operative complete and partial remission rates of type 2 diabetes mellitus were 50.9% and 78.7% respectively. We finally selected 11 models, including 6 scoring and 5 logistic regression models. Table 1 shows the complete overview of preoperative variables for each model. In the Hosmer-Limshel goodness of fit test, calibration values for ABCD and the individualized metabolic surgery were 0.07 and 0.14 respectively. The predicted to observed ratio of ABCD and IMS were 0.87 and 0.89 respectively. ABCD and IMS showed excellent results. Based on the research above, our conclusions are as follows. Type 2 diabetes mellitus were relieved to varying degrees 5 years after ASG in patients with obesity. The prediction models ABCD and IMS showed the best prediction effects. IMS was recommended for clinical use because of excellent predictive performance, good statistic test results, and simple and practical design features. ABCD can be used as a complementary method to predict remission of diabetes after ASG. Basically, that's all about my research. Thank you for listening. Distinguished chairs and co-chairs, good afternoon. It's my great honor and pleasure to share my research at this meeting. I am Yu Chengyuan, a postgraduate student from the Surgery Center of Diabetes Mellitus at Peking University, Ninth School of Clinical Medicine in China, with Dr. Zhang Nenwei as my tutor. Today, my report will focus on the comparison of various prediction models of type 2 diabetes mellitus in the Chinese population 5 years after Roux-en-Y gastric bypass. In China, over half of the adults are overweight or obese. Various prediction models of type 2 diabetes mellitus remission have been externally verified internationally. However, long-term validated results after Roux-en-Y gastric bypass surgery are lacking. The best model for the Chinese population is also unknown. So the aim of this study is to evaluate the prediction effect of various prediction models on the long-term diabetes remission after RYGB in the Chinese population and to provide reference to clinical use. To be specific, here are the methods of my research. First, we retrospectively analyze the data of Chinese who are 5 years after RYGB and externally validated 11 predictive models to evaluate the predictive effects of each model on long-term type 2 diabetes mellitus remission after RYGB. Inclusion criteria and the exclusion criteria are as follows. According to the diabetes remission standard formulated by the American Diabetic Association, partial remission, complete remission, and long-term remission are defined as follows. We conducted a comprehensive search of existing models and excluded those that didn't fit our study. Finally, here are the results. We enrolled 84 patients. Here is the baseline data. The 5-year post-operative complete and partial remission rates of type 2 diabetes remission were 31% and 70.2% respectively. We finally selected 11 models, including 6 scoring and 5 logistic regression models. Table 1 shows the complete overview of preoperative variables for each model. In the Hosmer-Limshel goodness of fit test, calibration values for ABCD and Simonas et al. were 0.14 and 0.21 respectively. The predicted to observed ratio of ABCD and Simona et al. was 0.83 and 0.88 respectively. ABCD and Simonas et al. showed excellent results. Based on the research above, our conclusions are as follows. Type 2 diabetes mellitus was reviewed to varying degrees 5 years after RYGB in patients with obesity. The prediction models ABCD and SMONA and all show the best prediction effects. ABCD was recommended for clinical use because of excellent predictive performance, good statistic test results, and simple and practical design features. SMONA's and OR's regression models can be used as a complementary model to predict remission of diabetes after RYGB. Basically, that's all about my research. Thank you for your listening.
Okay, thank you for your paper. 你好，我就是想问
Hello，
Hello， 你好，你会看过我
哎
们
，Hello，
上位人吗 ？OK， 不好意思，我的中文不是太好啊，所以
很好了，很好了。
所以我们就是想，为什么在这个两个 paper 都是好像差不多的，他们就是第一个就是 sleeve gastrectomy， 第二个就是胃道绕。然后我们在问，为什么在 sleeve gastrectomy 你用 ABCD 跟 IMS，and then 在第二个 paper 为什么你没有用一样的 prediction model， 你是用 ABCD 跟 Simone？
Thank you for your question. Firstly, we want to use two I use Chinese, okay, not frequently. 我们最开始是想用那个 ASG 和 RYGB 两种舒适一起做这个研究的，但是我们就是发现就是做的过程中，分开做用我们5年术后的患者的这个随访数据，来做这个 ASG 和 RYGB， 我们发现他们那个在进行这个模型的校准，用那个校正的时候，发现那个IMS 它好像在 RYGB 里边并不适用，就是它的校准是那个校准的数据不太行，然后我们就是剔除了这个在 RYGB 里边剔除的这个 IMS 模型，然后ABCD 是在两种术后的患者中，它的这个预测能力都表现非常突出的，但是我们是非常推荐用 IMS 的，因为它是一个网页计算器。这个网页计算器它在操作过程中，它是比这个 ABCD 这个评分模型，它是应用起来更为方便的。但是很遗憾，在 RYGB 里边，它那个因为在这个模型的校正过程中，它就是表现的不是很好，所以我们就剔除了这个 IMS。所以我们就在 RYGB 里边推荐这个 ABCD， 但是在这个 ASG 里边，我们依然是推荐这个 IMS 的。但是总的来说 ，ABCD 它在两种那个术后的预测中都表现得非常突出，所以我们会就建议把 ABCD 作为这个 ASG 的一个补充的一个预测模型进行那个临床应用。谢谢。
Michelle, you want to share that with us?
That was such a long answer. Okay. Basically, I think they find that one of them was not, from what I understood, was that one of them was not convenient for the other procedure. So that's why they decided to do different prediction models. Yeah, but the ABCD was pretty much applicable to both procedures. So was that correct, Wa?
For the IMS model, the data is not so good in the one-right gastric bypass group, but for the ABCD model, both procedures are okay.
Yeah, but why Simone? Why did they use Simone? And why not just? I mean, it would be nice if they could like use both models for, use similar prediction models for both procedures. But anyway. Very good. Thank you for your paper. Congratulations.
May I ask,
thank you.
May I ask another question? Can we just use the predictive model to predict and compare these two procedures to see which one is better for certain patients.
Actually, we were just talking about it because he presented two papers, one on sleeve and one on bypass, and we're wondering whether he's going to present a third paper in the next conference comparing the both.
可以吗？
Excuse me, I'm not clearly what the
就
question.
是能不能用这个 model 来就是预测两种手术之间的差异，就看一下哪个可能会好一点，哪个就没那么好这样子。
是这样，就是因为现在已经有那个前瞻性的那个研究已经说那个表明了这个糖尿病它在这个 ASG 和 RYGB 术后它10年其实差异并不大，患者的这个临床恢复就是部分缓解或者是完全缓解，他们其实是差不多的，所以我觉得就是对。我们所以就是如果说分开的去测哪个手术缓解的更好的话，就是现在目前觉得就是别人已经有这个10年的前瞻性研究的结果在这儿了，所以我觉得再做这个可能就是不是那么的好，对。
Okay, so Renu, you got it?
No, yeah, I absolutely got it.
Okay, he means because he found that in several prospective study, they showed that for the long-term result, the differences between sleep gastrectomy or volumetric gastric bypass are actually quite similar. No big difference, so they didn't compare that by using the models. And do you know? Have you noticed that actually Professor Vijay Lee, they update, modify the ABCD score to MABCD score, right?
Oh yeah, I heard it. Yeah.
Have a little bit change in the BMI and also in the duration of diabetes. They change the score, and so they can be better predict the results. Okay.
Congratulations again. And we look forward to seeing the
thank you.
comparison paper in the next conference, hopefully in China in November.
Thank you.
All right, so I think we missed out on one presenter in the morning. The session that involved bariatric surgery with BMI more than 50, which was the video by Tao Jiang, outcome of BPDDS and SADI in treatment of super obesity. So we could have that video. Is the presenter online? Okay.
Hello everyone, I'm Jiang Tao from China-Japan Union Hospital of Jilin University. It's a pleasure to share with you BPD, DS, and SADIs in patients with super obesity. Firstly, I would like to introduce 3 great doctors contributing to the BPD DS. The first great doctor to BPD DS is Scapinaro, who wanted to achieve the weight loss of the small intestinal bypass without the complications and the diadema of that procedure. To achieve that goal, in 1939, he performed a horizontal heme gastrectomy with post drainage by a rock lamp at last, 250 cm less, drawing a long, belly open carotid lamp to form the common ill segment or channel of 50 cm. In 1990 OS, Muscle and Hearst employed BPD and then consoled the modern BPD-DS by performing a sleeve gastrectomy with caloric persuasion, duodenal diversion, or proximal duodenalostomy, and a common channel of approximately 100 cm. Although BPD-DS is the most effective procedure for weight loss and remission of type 2 diabetes, it is the last common because of precision malnutrition risks. In order to reduce the nutritional risks and the difficulty of BPD-DS, meanwhile, written its excellent effects on diabetic remission and weight loss. In 2007, Sanchez proposed studies by reducing the anastomosis and lessening the common channel in the small intestine. In 2013, Sanchez intended the length of common channel to 250 centimeters so as to reduce the nutritional risks, while the set of gastric tube remained unchanged. In 2016, Brian Misman et al. Future employed studies by reducing the gastric tube to 42 FL and extending the length of common channel to 300 centimeters. Several studies have demonstrated that BPD-DS and studies showed similar weight loss and combative remission, and BPD-DS had more complications and supplementation. Since both studies and BPD-DS have very good effects on obesity, it is necessary to investigate and compare their effect on super obesity. Moreover, comparative studies on studies and BPD-DS in Chinese patients with super obesity and the complexity lacking. On October 13, 2018, Sudan professor was invited to our department to perform the first laparoscopic studies. Then we performed independently studies. From October 13, 2018 to October 20, 2022, a total of 149 studies were performed in our center. September 25, 2019, we performed the first laparoscopic BPD-DS. From September 25, 2019 to October 20, 2022, a total of 25 BPD-DS were performed in our center, of which there were 9 cases and 6 cases with super obesity undergoing studies and BPD-DS, respectively. This study aimed to compare the outcome of studies and BPD-DS in the treatment of Chinese patients with super obesity. 15 Chinese patients with super obesity undergoing studies of BPD-DS from October 2018 to December 2020 by the same surgeon were retrospectively analyzed. In the studies group, 5 were women and 4 were men with a mean age of 27.7 years. Their mean proportive body weight and body mass index was 109.3 kilograms and 52.1 kilograms per square meter, respectively. In the BPD-DS group, 3 were women and 3 were men with a mean age of 34.3 years. The mean proportive body weight and body mass index was 152.5 kilograms and 53.4 kilograms per square meters, respectively. All patients underwent successfully laparoscopic BPD-DS and studies without conversion to laparotomy or death. The operative time was significantly shorter in studies group than that of BPD-DS group. There was no scientific difference between studies group than that of BPD-DS group in terms of length of stay and complexion. The mean body weight in the studies group was 104.4 kilograms, 111.2 kilograms, 86.7 kilograms, respectively, at 3, 6, and 12 months after operation. The mean body mass index was 40.6 kilogram per square meters, 36.3 kilogram per square meters, 28.5 kilograms per square meters, respectively. The mean body weight in the BPD-DS group was 116.6 kilograms, 102.8 kilograms, and 80.9 kilograms, respectively, at 3, 6, and 12 months after operation. The mean body mass index was 41.2 kilogram per square meters, 36.0 kilogram per square meters, and 28.1 kilogram per square meters, respectively. There were no statistical difference between BPD-DS group and CIDES-B group in terms of body weight and body mass index at each follow-up point. In the CIDES group, the mean percent of excess weight loss was 39.7, 54.6, and 81.9, respectively, at 3, 6, and 12 months after operation. The total weight loss in the BPD-DS group was 40.2, 57.7, and 82.8, respectively. In the CIDES group, the mean percent of total weight loss was 22, 30.3, and 45.5, respectively, at 3, 6, and 12 months after operation. The total weight loss in the BPD-DS group was 22.8, 32.7, and 47.1, respectively. There was no statistical difference between CIDES group and BPD-DS group in terms of excess weight loss and the total weight loss at each follow-up point. The level of unrec outside in all patients with hyperuricemia decreased dramatically at post-operative 12 months in both CIDES group and BPD-DS group. 3 of 5 patients with hyperuricemia achieved complete remission in the BPD-DS group, and 4 of 7 patients of hyperuricemia achieved complete remission in the CIDES group. Except for 1 patient in the CIDES group, the level of triglyceride in all patients with triglyceride more than 1.7 mmol per liter decreased dramatically and returned to the normal range at post-operation to 12 months in both CIDS group and BPD-DS group. For patients with total cholesterol more than 5.18 millimole per liter, their level of total cholesterol in all patients decreased dramatically and returned to the normal range at post-operative 12 months in both CIDS group and BPD-DS group. For patients with low density lipoprotein more than 3.37 millimole per liter, their level of low density lipoprotein in all patients decreased dramatically and returned to the normal range at post-operative 12 months in both CIDS group and BPD-DS group. All patients with type 2 diabetes mellitus achieved complete remission at post-operative 12 months in both CIDS group and BPD-DS group. CIDS and BPD-DS offer a similar and excellent results for the treatment of superobesity and obesity-related metabolic diseases. Thanks.
Congratulations, wonderful paper. Dr. Wah, do you have any questions for him?
Sure. I don't have any question for Professor Tao Jiang. Maybe let me introduce Professor Tao Jiang. He is one of the vice president of CSMBS. Is our senior in our country, and he got a lot of experience, and especially in robotic surgery. If you have any questions, you may ask Professor.
Maybe I can just ask
Jiang.
one quick one.
Yeah.
Professor Tao Jiang, are you with us? Did we lose him?
He just turned off his camera.
Yes. Hello.
Hi. Good afternoon.
Hi.
Professor Tao Jiang, I'm Renu from Malaysia. Just one question. There was one patient that had the elevated triglyceride levels. Any idea why that happened?
杨华帮我翻译一下啊。杨华，你听到了吗？
Renu, would you repeat your question again?
I think there was one patient, was it triglycerides?
Oh.
There was one patient with the, if I'm not mistaken, triglycerides, which was elevated 12 months post-operative. Is there any?
他说有一个甘油三酯升高的那个是怎么回事？
对，我们确实发现帮我翻译一下啊。这个手术以后
不要讲太长哈。
对血脂的，它有的时候脂肪肝包括血脂呢，有的时候确实升高了，这是我们也发现这个现象，我们也在研究这个 BBD 和3D 以后的肝功能改变，希望以后随着病毒增加，我们有一个结论啊。
They don't have any conclusion yet, but they are collecting the data because they observe several elevation in the lipids profile.
Yeah, I'm asking that because I see that in my patients in Malaysia. I repeat the blood works at 12 months, and I noticed that some patients do have these elevated levels, and then they panic. They go and speak to some doctors, and then they get all kinds of information, and then they come back and panic. But when I repeat the blood test, at 18 months and 24 months, it comes down. So there's a up at 12 months, and then it comes down at 18 and 24 months. So I was wondering whether you're seeing the same thing if you're following up on these patients that had that transient up trend.
Yeah, they are doing that, and maybe they will share the data later. Yeah.
Yes. Okay.
So
right, fantastic. So we will wrap up the session for today. Thank you so much to all our speakers, all of you who contributed to your video presentations. It is immense pleasure for us as Young IFSO APC to have all of you on board. And we look forward to having you all in person for the next meeting. Hopefully we'll have one in China if the doors are open. Otherwise, we will see you in IFSO Napoli in 2023.
Yeah, and I
Take
hope
care.
more abstracts from other countries as well.
Yes, yes,
I'm so
correct.
surprised that all the abstracts are from China. Yeah.
Yes. Philippines, what happened? Malaysia, what happened? All right, maybe next session. Okay, so thank you very much and see you guys in the next conference. Have a good day. Have a good weekend. Bye.
Thank you. Bye-bye.
Thank you. Bye-bye.
Well, stay online, stay online. We're taking some photos. Stay online.
Okay.
Can we take a screenshot with you? Can we send it? Okay, we will project him on the screen. Cannot see us.
Okay. Can we start? Okay. Now we would like to start oral and video abstract session.
Maybe since we have a lot of not here yet, we can go with discussion.
Discussion? Oh, yeah, short discussion. Now we would like to start oral and video abstract session. I'm Masai Kyoto from Japan, and we would be chairing this session. My co-chairperson is Dr. Paulo from Philippines. In this session, there will be a short individual discussion after each presentation, and comprehensive discussion after all presentation will be performed if we have time. The first speaker is Dr. Liu. Dr. Liu, please.
Take it away, Dr. Liu.
And each presentation time is 6 minutes because the schedule is very tight. Okay?
Oh, good. Okay. All right. Hello, everyone. Thank you very much for having me. My name's Daniel. I'm a medical student, currently working with Dr. Ken Loy in Sydney, Australia. So today I'm going to be talking about or presenting an abstract on the topic of patient satisfaction following superannuation-funded bariatric surgery. So just a bit of background for my non-Australian friends. Superannuation in Australia is a compulsory scheme where an employee has a percentage of their income paid by their employer into a managed fund so that they have a body of savings when they retire. A superannuation fund is essentially a retirement fund. Apart from exceptional circumstances, these funds usually cannot be accessed prior to the age of retirement. With bariatric surgery in Australia, over 90% of procedures are privately funded and performed electively in the private health system. Thus, a significant barrier for patients to access bariatric surgery is the financial costs. While there is a very small number of bariatric surgeries performed in the public health system, there's a strict set of criteria which precludes the majority of patients who are seeking such procedures. Even for the patients who do meet the criteria, there can be a wait time of up to 2 years or more before patients meet the metabolic obesity surgery team. And even then, there's no guarantee that patients will receive surgery or even meet the bariatric surgeon. So patients who do not meet these criteria are thus required to seek bariatric surgery through the private health system using private funding or private health insurance to fund their surgery. In Australia, the patient's superannuation can provide a unique source of funding which can be used to alleviate the financial costs in patients seeking elective bariatric surgery. So the aim of our study is to assess the satisfaction of patients who have accessed their superannuation to partially or fully fund their elective bariatric surgery. So what we did is, in a private bariatric practice, 33 consecutive patients who funded their elective laparoscopic sleeve gastrectomy via their superannuation fund in 2020 to 2021 were identified. All of these 33 patients were contacted within 1 year, or 1 year post-operatively, and of these patients, 22 provided consent for this study and completed our 12-question telephone questionnaire. Our questionnaire evaluated patient satisfaction by evaluating their overall satisfaction, the ease of accessing their superannuation funds, and the timeliness of accessing such funds. So we found that the median time for accessing surgery from superannuation downdraw was 4 weeks. As you can see from these pie charts, 95% of patients were satisfied with the use of using super to access bariatric surgery, with 100% of patients finding that this process was effective. In these patients, 95% reported benefits to their health resulting from bariatric surgery, and the most common reason to access super was either lack of personal funds, recommendations from family and friends, with half of our patients reporting that they would not have access to bariatric surgery at all by other means. All of our patients would recommend the use of super-funded bariatric surgery to others, and 77% of patients reported no barriers and no difficulties in accessing surgery via this channel. So this is the first study of its kind, to the best of my knowledge, to evaluate patient satisfaction following superannuation-funded elective bariatric surgery. In our small cohort of patients, the results are strongly suggestive that patients are satisfied with the use of superannuation downdraw to fund their surgery. It is clear that superannuation has provided a financially viable route for accessing bariatric surgery, allowing patients to receive gold standard curative treatment for a life-limiting illness. The economic benefits should also be highlighted. Bariatric surgery is not only cost-effective, but in the long term it has been shown to be cost-saving for patients, with its initial cost offset by the longer-term savings in the cost of obesity for the patient. However, further studies are needed to assess the health economic impacts of superannuation-funded surgery, including taking into account the longer-term patient data and the emotional and financial capital that the patients pay. Thank you very much for your time and attention.
Thank you, Dr. Liu. So now this question is open, and I want to know the patient's average age in this study.
Yep, thank you. So in terms of the patient's average age, unfortunately I don't have the current data with me, although it is in the data set that I've got on my computer, so I'm happy to sort of look it up afterwards and let you know.
No data.
Oh, it's not currently with me in my presentation, but I have it on the Excel sheet. So, I think roughly for our patients, they're usually around like in the 50s. So the average age is around 50.
Oh, really?
Yeah.
Oh, okay. Thank you.
The average age of the patients that we in that cohort was between 30 and 50. The ages of 30 and 50. Yeah.
And actually, in my opinion, thank you for sharing that. Is this a compulsory thing?
No.
I mean, companies, yeah. So there's no compulsory method. So how is this conceptualized?
So accessing the superannuation isn't a compulsory thing. So if patients have their own source of funding, they can use that.
Okay.
And if they have private health insurance, then the private health insurance can also cover part of that cost. So it's up to the patients. It's an option available for them if they don't have insurance and they'd like to have another source of funding available.
This is a very interesting topic because a lot of the Southeast Asian nations have tried to find ways to fund this type of surgery. And you're right, to my knowledge too, I haven't seen any study on the economics, and I think it should be processed a little more. I think the other doctors here would agree with us. Thank you very much.
Thank you very much.
This is a nice introduction to the economics of bariatric surgery. So, well presented. Thank you very much. So our next presenter is from Taiwan. Dr. Yawei Huang, correct? Okay. She will be presenting e-health intervention via line social media as an adjunct for post-operative care after bariatric metabolic surgery. So, care to share with us which institution is this?
Hello, good afternoon. I'm Yawei Huang, and after another surgeon, I'm a bariatric nurse. So let's go ahead. And applying e-health intervention via social media are common in modern medicine, particularly during the COVID-19 pandemic these couple years. And in Taiwan, Line is the first among the most used social media platforms, with 88% of internet users ages 16 to 64 years. And it can provide free messages and video calls 24 hours a day. So it's easy for bariatric nurse and the patients to have a bidirectional communications. So this study was to verify whether Line could be used to provide healthcare consultation and the support for patients with bariatric surgery. And in study method, this study was a total of 143 native patients aged over 20 years old with BMI over 37.5 over 32 with comorbidities. All of them underwent RYGB and SG procedures, and their study period between 2016 and 2020. And all the data collection includes the pattern of line communication with the bariatric nurse and associated action to resolve patients' needs within 6 months after discharge. But revision surgery and complications, stabilized leak, for example, were excluded. And the table 1 presents the variable for the two groups, RYGB and RSG, differed in characteristics or age, body weight, BMI, and the total weight loss at 6 months and 1 year. Moreover, diabetes patients with insurance treatment were 50% in RYGB group compared to RSG 11%. And the average frequency of chronic visits within 6 months showed a significant difference between the RYGB group and the RSG groups, were 48% and 2.2% respectively. And the table 2 here only address the top 7 reasons for consultation service via line app. And you can see the diet problems were the most patients' concerned issues in 2 groups. And the weight problems were more concerned in the RSG group, and in the RYGB group, patients were concerned with medication and diabetes control. And this figure presents regarding the patient's concern during the different post stage after discharge. Diet problems remained the most dominant issues throughout the post-operative recovery. And most patients concerned could be resolved by the bariatric nurse via line, the consultation service with 94% of messages. Moreover, only 6 patients were transferred to the emergency department, present complaints of fever, intractable hiccups, abdominal pain, and dyspnea. So most patients had diet problems after weight loss surgery, include food tolerance issues and eating behavior modification. Considering the faster recovery with early discharge to patient after bariatric metabolic surgery. The line consultation service could be used to recognize the patient who indeed required further healthcare counseling to prevent possible adverse events leading to readmission, such as dehydration or other complications. So e-health intervention have been recognized as effective adjunct to support medical staff to take care of patients after discharge. So in conclusion, our results demonstrated that the line consultation service could efficiently address patients' concerns. Such a patient-centered e-health intervention might reduce the need for unexpected emergency or chronic visitors and improve post-operative weight loss surgery follow-up care. Thank you.
Thank you, Dr. Wang. So my question for your topic, is Line the go-to app that is used in Taiwan?
Yes.
So majority of patients would communicate through Line?
Yeah. I think all Taiwanese, we use Line much more than other social media.
Okay.
Yeah.
My concern would be, since it's a social media platform provided by a third-party provider, is the information that is being shared between you and the patients regarded as safe?
Because it's just like a WeChat or something, and always if we have something emergency or patient were concerned, always we can just follow by the phone.
Okay.
So I think, and I think it's quite safety, and it's just for patient with me, we just like a communication is a tool.
Okay.
Yeah.
So it's mostly used as a tool. So how were you able to document all of this information over the years? I'm very curious on that. I mean, you mentioned it's from 2016 to 2021.
Yeah, exactly. Actually, it's total 1,200 messages. So we analyze it around 1 year. So it's a big data.
Oh,
yeah,
okay.
exactly. Yeah.
So maybe you should look into data encryption.
Yes.
Are they sharing pictures? Are there anything else being shared across the platform? No. For example, if a patient had bleeding or something like that, they would probably take a picture of that and send it to you.
So because it also provides the video call. So also we can just face to face. Yeah.
And
exactly.
any thoughts of your group developing something like a more closed platform? You know, an app, for example, that it's only for you, dedicated for you?
No. Sometimes if I got any concern to my patients or any questions, I just phone my surgeon.
Okay.
So surgeon is my consultation.
Okay, thank you. So, any questions, Professor? Any other questions from anyone curious about using social media? This was a lecture earlier. So anyway, thank you very much, Dr. Wang. I'd like to know, Jason Wijaja still? Okay, so we will skip the third presenter from from China. We will now move to our next presenter, Dr. Jennifer Yang.
Good afternoon, everyone. So my name's Jennifer. I'm one of the junior doctors at St. George Public Hospital in Sydney. So today I'm presenting the the preliminary findings from an ongoing study currently being conducted at St. George Private Hospital and East Sydney Private Hospital, examining the safety of a novel endoscopic stapler, the iReach Magnum-powered stapler, specifically in the use of laparoscopic sleeve gastrectomies. So I'd also like to thank my co-authors listed in the presentation, particularly the Senior Supervisor, Dr. Ken Loy, who's also the incoming IFSO President. So before I begin, I'd also like to thank Leanne Rogers, as well as the rest of the staff at St. George Obesity and General Surgery, and also the Medical Records Department at St. George Private Hospital and East Sydney Private Hospital, without whom the data collection for this project would not be possible. And also the UGI Metabolic Research Foundation for providing the travel grant, and I've got no conflicts of interest to declare. So to begin with a bit of background, as I'm sure everyone here is already aware, the global prevalence of obesity is increasing. In fact, it's predicted that by 2030, 1 billion people worldwide will be obese. And amongst treatments for obesity, bariatric surgery is the most effective treatment, resulting in much more sustained and more significant weight loss compared to traditional methods such as diet, exercise, and even medications. Amongst bariatric surgery procedures, the laparoscopic sleeve gastrectomy nowadays is the most popular procedure and accounted for 61% of bariatric surgeries worldwide between 2021 and 2022. So laparoscopic staplers are integral pieces of equipment in bariatric surgery, particularly the sleeve gastrectomy, where their function is to transect the gastric tube as well as facilitate concurrent hemostasis. So as technology continues to advance, new stapler devices are being developed with the focus on improving ergonomics and also reducing the likelihood of complications during the surgery. So amongst these novel devices, the iReach Magnum-powered endoscopic stapler is a new offering currently on the market, and that's the focus of our study today. So this is a photo of the iReach Magnum-powered endoscopic linear stapler. So some key potential new advancements to highlight include the fact that it offers up to 55 degrees of articulation in both directions, and also it provides audible feedback to the surgeon after 15 seconds of pre-compression time. So since with these new staplers, there's currently very few studies actually directly comparing the safety and efficacy of different staplers, The aim of our study, therefore, is to compare the short-term safety and efficacy of the iReach Magnum powered stapler with that of the established powered stapler system at our facility. So our hypothesis, therefore, is that the overall rates of surgical complications, as well as the operating times, will be similar between these different stapler devices. So in terms of our methodology, this was a retrospective comparative study conducted on a prospective database of patients undergoing laparoscopic sleeve gastrectomies from February this year to present. And these were conducted by a single surgeon, Dr. Ken Loy, at St. George Private and East Sydney Private Hospital. So our target for patient recruitment was to recruit 50 patients in each group, and these were recruited consecutively. So data for each patient was then collected from both the electronic and paper medical records, and we looked at things such as patient demographics, their follow-up to look at the amounts of weight loss, any intra and post-operative complications, as well as the operative times. And the statistical analysis was then conducted in SPSS with chi-square tests and Mann-Whitney U tests. So these are just the preliminary results because data collection for this project is still ongoing. So at the time of this analysis, 81 consecutive laparoscopic sleeve gastrectomy patients had been recruited, 34 in the iReach group and 47 in our consecutive stapler group. So the median length of follow-up was similar for both groups, averaging the median being 40 to 50 days. So in terms of the outcomes, in fact, only one patient in each group actually experienced the complication, and both of these were grade 1 superficial skin infections. So in both groups, there was no grade 2 or higher complications. And the median operative times was also similar between both groups, being 43 minutes for the iReach and 53 minutes for our conventional stapler. Therefore, our preliminary conclusion is that the iReach Magnum powered stapler appears to have a similar short-term safety profile and ease of use compared to the established powered stapler system at our facility. So with the project, we're still continuing ongoing data collection to reach our target of 50 patients in each group, and also completing up to 1 month of follow-up, completing at least 1 month of follow-up for each patient. Does anyone have any questions?
Thank you very much. I have two questions. First question is that conventional stapler is what product? And second question, and how do you buttress the stump of stomach for sleeve gastrectomy?
Is there any buttressing involved of the, so I think it's more of a technical thing. So, okay, the question probably better, after stapling, nothing else is done. Is that it?
Yeah, so my fellow, Dr. Daniel Chan is actually in the audience.
Dr. Loy is actually also in the audience.
And Dr. Loy is also in the audience. I might defer the question to the both of them.
So,
the conventional one is Signia, and the buttressing been used in both cohort. So I routinely use buttress in all stapler.
Okay, there you have it. I didn't get it earlier, but it mentioned there that you already had 30% of the cases already done with the, what you call this, the iReach, and the other group is already around 40. Is this a randomized thing?
So we, it's not, I can't answer whether it was randomized because we just collected the consecutive patients undergoing the laparoscopic sleeve gastrectomies. So in the 81 patients who had had the procedure done between February to when this presentation was written, 34 of them happened to be iReach and 47 happened to be conventional.
So there was no like method that you use. Other studies would employ like we start with iReach, then alternating. There's no randomization being done.
To the best of my knowledge, no. And I think Dr. Loy is.
No randomization. It's just a comparative study. So the randomization will probably be too difficult. I think you will require a significant amount of ethical things to go on. So we just collect the data consecutively and then compare the demographic and see if there's any differences. Yeah.
Thank you very much, doctor. So you heard there's a lot of things that you have to consider, like IRB, etc., when you have to go through randomization. But it will make your study stronger if you're planning on gonna go for this. You have to plan it really well. But okay, thank you very much. We'll be expecting a lot from when you complete this study, 50 cases, sir. Thank you very much. We now move to our next, again from Australia, Dr. Kie Cheng. Kie Cheng.
Should we just start? Yeah. Good afternoon, everyone. My name is Cheng. Thanks for giving us the opportunity to present this research paper here, and also, obviously, the Philippines to host us, which has been fantastic. So this paper relates to the outcomes of sequential placed Obera balloons for weight loss and a proposed treatment algorithm. Again, the data comes from my center. I'm a bariatric upper GI fellow at St. George Hospital. Most of the data comes from St. George Obesity and General Surgery. So I've got nothing to disclose. Background-wise, I mean, this has been touched on multiple times. Obviously, obesity is a big problem. It's becoming a world pandemic, more so than not in Australia. As we know, bariatric surgery is the gold standard when it comes down to weight loss as well as metabolic operations, but it does have a significant risk profile. And again, not everybody qualifies. Obviously, we've known that the IFSO as well as the ASMBS guidelines have been recently published, and the BMI criteria is definitely changing, but as of now in Australia, it still follows the NSMOS kind of guidelines on the 35 cutoff. Bariatric endoscopic procedures most certainly have their place as an adjunct or as part of an arsenal of what we can use when it comes to weight loss. And one of them being the intragastric balloon, which has been used quite extensively. So to the best of our literature search, there has been very little data comparing different BMI groups of the lower BMI 27 to 35 and above the 35, as well as looking at sequential balloon placements and the results. So this is the basis of our study. So methods-wise, we did a retrospective review of a prospective maintained database that was taken from 2017 to 2021. Essentially, it's a single surgeon experience across 3 Sydney centers. And what we did was we broke up this patient population into 2 groups. We analyzed it separately into the BMI 27 to 35 and the BMI greater than and also equal to 35. We've excluded patients who were concurrently on pharmacotherapy, as well as patients who did not attend follow-up. So the balloon that we used was the Obera intragastric balloon, and this balloon in itself was the 6-monthly balloon rather than the 365, which I believe haven't come out at that stage. But we are experimenting with that at this point of time as well. Balloons obviously placed endoscopically with the volume of about 500 to 600 mils placed inside. Patients are progressed through a liquid diet and are regularly followed up in the rooms with the dietitian as well as with the specialist at the 1 and 3 as well as 6-month mark before when the balloon is then removed. Now, for the sequential balloon, it is placed at the same time that the balloon is taken out. And how patients get selected for this, they actually select themselves. So obviously, given that it is a self-funded procedure, it's very hard to convince patients to have sequential balloons in all of them. So when we look at the results, the patient population in terms of age and sex are actually quite well matched. BMI is obviously different because we're looking at the different cohorts. And the comorbidities, well, the BMI 27 to 35 has a relatively lower type 2 diabetic rate. And just in terms of how many people actually had more than one balloon placed, that's 27% in the first group and 24% in the second. So weight loss outcomes. So just looking at, this is for the first balloon, the total body weight loss at 6 months was more with the lower BMI group when compared to the higher BMI group, and this was actually statistically significant. This was a secondary outcome that we looked at, so adverse outcomes after the balloon insertion. Now, these procedures are quite benign in that there's relatively low rates of complication, but there are still adverse symptoms that patients do get. And one of the most common symptoms that patients get in terms of balloon intolerance is reflux, as well as dysphagia. And when you total patients who had more than or equal to one symptoms, you can see that a lot of the patients actually had that. But for majority of the patients, they were able to tolerate this, and the early extraction was only 18 versus 31%. So looking at the second balloon insertion, so this is where our cohort was actually much smaller compared to the first one. The volumes were similar. But what was interesting was that you can see that the additional weight loss following the first balloon versus the second balloon insertion was significantly lower. So with the second balloon in the lower BMI group, that only inverted to about a 0.5 kg weight loss and a 4.2% weight loss in the BMI greater than equal to 35 groups. When we looked at cumulative weight loss from the beginning of therapy, as in the first balloon plus the second balloon, we showed that the total body weight loss percentage were actually quite similar when you compare it to the BMI 27 to 35 versus the BMI greater than equals to 35, which actually just means that the higher BMI patients required a second balloon to get to the same kind of weight loss potential that is expected of somebody who had a single balloon in the lower BMI group. So just a few discussion points. With the single balloon, with our data, basically it showed that it was more effective in the lower BMI group compared to the higher BMI group. And with the second balloon, it was very much a matter of diminishing returns. Having said that, in the higher BMI group, it did seem that the second balloon did benefit them more, getting them to lose a little bit more weight. Again, there's very minimal complications with the balloons, but obviously we do need to consider all the adverse outcomes that can happen with the balloons. We didn't actually look into this too much because there wasn't that much patients with diabetics or diabetes as well as other metabolic disease, but there was a slight decrease in HbA1c in the patients who had the balloons as well. So I just checked that in. So how do we incorporate this into our practice? So this was the algorithm that's been modified in relation to this study. So when we look at the first lower BMI group, obviously before introducing them to any kind of interventions, we trialed diet, exercise, and pharmacotherapy. In the setting of being ineffective, then we would talk to them about a possible balloon because they wouldn't qualify for bariatric surgery, unfortunately, at this stage. And if they were effective, great. So that's where we stop. And then we try to maintain it with good lifestyle changes as well as ongoing follow-up. Now, if they were ineffective with the balloon, then we would, at that stage, for the higher BMI patients, would start talking to them about possibilities of bariatric surgery. Looking at the higher BMI group, very similar kind of flow pattern, but this is crucial. Basically, we would talk to these patients about bariatric surgery once we know that they've failed the diet, exercise, and pharmacotherapy. This is the first line thing that we consider. Now, obviously, that's up to the patient to take that up or not. And if they didn't want to and they wanted a balloon instead, that was something that we would counsel them on as well. And again, if it's effective, we go down the other pathways. If it's ineffective, then we re-engage them with that bariatric discussion. Okay, thank you very much.
Thank you very much. I have one question. In Japanese data, including about 400 cases. So in this study, so we found this, BMI, so less than 35 patients had more frequent rebound compared to the more than 35 BMI. Are you following the patients with balloon treatment after balloon removal?
Sorry, I didn't catch the last part.
I think he was saying the follow-up with patients who have failed. You remove the balloon and they stopped going with the balloon.
Because low BMI patients is easy to have higher percent excess weight loss and percent total weight loss.
Yeah, no, absolutely.
So easy to have a rebound compared to the more than 35 BMI.
Yeah, no, absolutely. So the
your criteria is very nice, I thought, but actually, are you following up the patient or not?
We try to. I think that's the most important thing. A lot of times we try to follow these patients beyond 1 year, but it depends on whether the patient actually follows up with us or not. But what data we have, we've already excluded all those who did not follow up. What data we have is between 6 months to 1 year data here. But I definitely agree, balloons have a chance for weight regain. And this is why, it's mainly used as an adjunct rather than a main therapy. Absolutely.
Regarding the use of the balloon in terms of, with regard, do you frequently also monitor the patient while on balloon? Like, for example, their diet, are they guided with the type of diet they're having?
Yeah, absolutely. So we've got a dietitian in the rooms that see them at the same time. Yeah.
Okay. Yeah. Okay. Thank you very much, Doctor. So for our next presenter from Taiwan, to present a preliminary experience with 1 year result of endoscopic sleeve gastroplasty from Asia, learning curve of one bariatric surgeon. Thank you very much, Doc.
Okay, everyone, Chairman, I'm glad to be here share our short-term experience of the endoscopic sleeve gastroplasty. And I'm a general surgeon, and I always come from Taiwan. And my hospital is Kaohsiung Veteran General Hospital. And this is the 2080 guideline for bariatric surgery. And the bariatric BMI of the correct surgical indication is more than 40 and 35 with comorbidity. But in Asia, the BMI of criteria is reducing 2.5. So obesity, there is a gap between the 27 and the 32.5. And the medication may be a good choice, like Lenico or GLP-1 for treatment of the obesity. But what kind of rapid advanced field we can support for the patient? And the rapid advanced field, as we know, intragastric balloon is a good tool to controlling body weight. But in Taiwan, 3 years ago, the intragastric balloon is terminated, so we cannot afford intragastric balloon for the patient. So we follow the endoscopic suture system. Although endoscopic suture has been created and it had been proved, it had a good result for treatment of obesity. And this is the brief endoscopic suture history. In 2004, it was first described, and in 2008, the first generation of stitch was approved, but it must be used double-channel endoscopy. And till 2017, the second generation was approved. It became easy. It just used the single-channel endoscopy, we can perform the endoscope suturing. And initially, endoscope suturing just for the gastric fistula or leakage or the defect of the ESD. And this is the suture system. The left is the first one generation, and the right is the second generation. In 2010, Bressauer introduced the transoral gastric ballon reduction procedure. They do 18% patients, and they do 4 to 8 application, and their procedure time is 125 minutes. And no serious or other related complication was reported, and it showed weight loss and the improvement of comorbidity. After that, you can see that many population was reported and showed good results. And we started the endoscopic sleeve gastroplasty from November 2020. We followed the suture method by the Professor Nato. We used the suture method by the rectangle or the usual pattern suture. And why is the advantage of the ESG? ESG is incisionless. It can be the same day or outpatient procedure. And it causes mild pain and mild nausea. And the patient can go to work and in 2 or 3 days. And the mechanism of ESG is a restrictive procedure. It causes the gastric ballon reduction and shrinking, but it must be whole layer suture. So it induces the early satiation. The second mechanism is that it causes the delayed gastric empty. And the mechanism of the ESG and the LSG is different. LSG causes the reflux genetic procedure, and with high pressure and low compliance system. And ESG is organ preserving procedure. It keeps the vessel and the nerve and preserve the low pressure and high compliance system of the stomach. And who should be considered for the ESG? If the body mass between the BMI between the 27 or 32.5 or higher, or patient unable to lose weight through diet or exercise alone, or patient not interested in surgery or afraid of surgery, they can do the ESG. In Taiwan, this patient is more. And no major medical problem and no psychological problem. And this is our ESG procedure. And the right lower is complete. You can see the gastric tube like the LSG. And then let's see our learning curve. In one prospective study case, its learning curve, its procedure time is about 105 minutes, and the reach plateau is 101 minutes. And this is our learning curve. Our learning curve with the plateau is about 138 minutes, and our learning case is at about 10. Why we spend more time to reach our learning plateau? Because we are surgeons. We did not do the endoscope every day. And this is our the curve. It's about 10 cases. And talk about the efficiency of the endoscope sleeve gastroplasty. In this 2021 Singapore, you can see 1 month and 3 months and 6 months. Its total body weight is about from 62.4 and to 16.2. And this review article, you can see the 6 months and the 12 months and 1 year. And 1 year total body weight loss is about 15.7, and 6 months is about 17.1, and 18 months is about 17.3. And this is another review. You can see the 1 month and the 3 months and the 6 months and the 12 months. It's the same like the previous. And then this is our general data. We've done the 73, and the 38 were the male patient, and the 35 was female patient. And the male age is around 20 to 55, and the female is about 18 to 68. And this is our average BMI. The male minimum BMI is is about 26, and the measurement is about 47. And the female, the minimum BMI is about 27, and the measurement about 52. And this is our result. We found our man's total body weight loss is about 66%, and the 3 months is about 9.6%, and the 6 months is about 13.3, and 1 year is about 16, and 18 months is about 18.6. ESG also have the complication that bleeding, nausea, pain, or perigastrial fluid coagulation or pulmonary emboli, but the majority are non-fatal. And this is a Singapore report. They show the post-operative pain is about 46, and the vomiting is about 23%. And in this 2020 review, you can see the abdominal pain and the nausea about 72%, and the severe advanced event just about 1%. And we can see why is the serious advanced event, include intra-abdominal coagulation, hemorrhage, or refractory symptom require ESG reversal or pneumoperitoneum or pulmonary emboli. Its total occurrence rate just 1%, and no mortality was reported. And this is our experience. Our experience is just one perigastrial fluid accumulation, no mortality. And we got a 5-fit failure experience because for first-time patient. And the 4 patients received a second-time ESG. Why we know the patient is failure? Because when patient came to the OPD, they said the satiety did not change. The patient got the body weight again. And we repeat the endoscope. And we will see the stomach is full expanded, and we can see the thigh is loosening. Why caused the failure? Because we are not familiar to the upper choke system initially. And the stomach is not well insufflation, because initially we did not use the CO2, but when we use the CO2, the stomach insufflation is well. Another problem is something goes wrong with our endoscopy. And if the stomach is not well insufflation, you cannot do the whole layer suture or spider. All patients, when they came back, they did not obey our post-operative eating program. So comparison, endoscopic gastroplasty is developed for years and safety. Either endoscopist or general surgeon, you must create a multidisciplinary team, and before endoscopic sleeve gastroplasty. And the ESG procedure seems simple, but is technically dependent. Thank you.
Thank you very much. I have one question. I confirm. So whether the ESG is now covered by government health insurance or not? Maybe not.
No.
Okay.
Totally self-pay. Yeah,
Totally
it's
paid.
very expensive. About in Taiwan, about 2,100. Yes.
Okay. Thank you very much, Doctor. For our next presenter, we have a presentation from Korea. Dr. Chung Yuna will be presenting continuous transverse abdominis plane block after laparoscopic sleeve gastrectomy in 50 consecutive cases.
Hello, my name is Yuna Chung. I'm a bariatric surgeon from Seoul, Korea. And today I will be presenting on continuous transversus abdominis plane block after laparoscopic sleeve gastrectomy. The TAP block was first introduced in 2001 by an anesthesiologist, and this new approach involves identifying the neurovascular plane of the abdominal musculature and injecting a local anesthetic agent. He described that the 7th to 11th intercostal nerves, subcostal nerve, iliohypogastric, and ilioinguinal nerves all run variable courses between the internal oblique and the transversus. Oops, excuse me. So all of these nerves run their variable courses between the internal oblique and transversus abdominis muscles, and suggested that this plane may be ideal for decreasing postoperative abdominal pain. Furthermore, the updated enhanced recovery guideline from the World Journal of Surgery in 2021 strongly recommended that opioid-sparing anesthesia with a multimodal approach, including local anesthesia, should be used in order to improve recovery. Although there is not enough evidence to endorse a specific modality yet, ultrasound-guided tap block was mentioned to decrease pain and opioid requirement while improving time to ambulation. The transversus abdominis muscle is located below the ribs and posterior to the rectus abdominis muscle near the midline, and external and internal oblique muscles laterally. Approaching the transabdominis plane from the subcostal and lateral aspect allows access to the nerves at the T6 to T12 levels, which innervates the upper and anterior abdominal wall. These figures shows where to position the ultrasound probe, and figure 4 shows the ultrasound view from the midline, and the point of deposition of the local anesthetic is posterior to the rectus abdominis muscle and above the transversus abdominis plane. And we position the needle from a medial to lateral direction, and from the lateral view you can see that the point of deposition would be posterior to the internal oblique muscle. Approaching the tap plane with ultrasound guidance is underutilized, and this may be because there is no specific recommendations and lack of evidence, and also because it could be considered inconvenient. Enhanced recovery after bariatric surgery is important for decreasing morbidity and enhancing functional recovery and shortening the length of stay. Ultrasound-guided tap block has been known to decrease pain scores and opioid requirement after bariatric surgery, and we aim to investigate the efficacy of continuous tap block in 50 consecutive cases of laparoscopic sleeve gastrectomy. From February 2022 to April 2022, 50 cases of laparoscopic sleeve gastrectomies were performed with ultrasound-guided tap block. The data was compared to that of 201 cases of primary LSG that had been performed from January to December 2021. We initially intended to match the two groups, but the baseline characteristics were homogeneous, and we decided to include all of the cases from 2021. Ultrasound-guided tap block was performed from the epigastric ports, where the 3 to 5 millimeter incision was made for liver retraction during LSG. The lateral border of the rectus abdominis muscle was identified under ultrasound guidance, and a 17-gauge T-peel inducer and sheath were inserted in a medial to lateral direction towards the tap plane. 15 to 20 cc's of normal saline was injected after negative aspiration for plane dissection, and the catheter was inserted through the sheath after removal of the inducer. The same was performed for their other side in the same order, and 100 milligrams of 0.5% bupivacaine was injected into the elastomeric pump. These are the baseline characteristics. There was no significant difference in mean age, initial body weight, preoperative body mass index, incidence of diabetes, hypertension, obstructive sleep apnea between the tap block group and the non-tap block group. The tap group had a higher incidence of dyslipidemia at 80%. There was no significant difference in the perioperative outcomes, including length of hospital stay or complaints of nausea or vomiting. This table shows the postoperative medication for PONV and pain control. Although there was no significant difference in 24-hour cumulative opioid consumption, The TAP group had significantly lower percentage of requests for opioid in the postoperative 24 hours and requests for ramosetron for nausea in the postoperative 24 hours as well. This figure shows the change in NRS score over time. 0 indicates the non-TAP group, and 1 indicates the TAP group. Although statistically insignificant, the TAP group surprisingly seemed to have a higher NRS score compared to that of the non-TAP group. This may be due to the inconsistent methods of documenting the intensity of pain, and the TAP group seemed to experience visceral pain more intensely, but we were unfortunately not able to find a way to distinguish somatic and visceral pain based on the NRS score. There were 2 cases of complications related to continuous TAP block. In 2 cases, there was difficulty in removing the catheters, and we needed to remove them under local anesthesia. And although continuous TAP block did not reduce cumulative opioid consumption, the need for additional opioid and antiemetic injection can be reduced within the postoperative 24 hours. Thank you for your attention.
Thank you so much. I have one question. So, TAP block is very effective compared to the conventional pain treatment. But I want to know the TAP block has cost effectiveness or not?
Actually, it is expensive. It costs more for the patient, but it wasn't a significant amount of money. It was a... What is more expensive? Opioids, yes, that's true. But our... Well, I'm not sure, to be honest.
I just wanted to clarify. So you guys use pain busters?
Yes, we use pain busters.
Okay. What about just injecting? And did you look
well, actually,
into
the action time is around 48 hours, but we wanted to make sure to be able to reach the complete TAP plane, and we felt like a continuous infusion might have better effects.
And you usually take it out day 3? Is that day 2?
Yeah, at day 3.
Okay, thank you.
When you do this, is the patient already anesthetized, right?
Yes, before we end general anesthesia.
Okay.
The surgeons, I performed it.
The surgeon does the blocking, not the anesthesiologist?
Yeah, I did it.
Oh, okay.
Okay.
Oh, really? Yeah.
Well, our anesthesiologist...
So these patients, they're covered by the insurance when you go for this?
The national health insurance,
okay.
Yes.
Thank you very much. Thank you. For our next speaker, we have early outcomes after 1 anastomosis gastric bypass, a single center experience. Our presenter is Dr. Angelica Delgado.
Hello, good afternoon. My name is Angelica. I'm from the Philippines, but this data was gathered in Singapore when I took up my fellowship. So I'm here to discuss the early outcomes after OAGB, and I worked in the National University Hospital in Singapore. So just a brief background, we all know that OAGB has been gaining popularity for the treatment of morbid obesity, especially since recently it has been endorsed both by the IFSO and the ASMBS. Now, the data on outcomes and complications, especially the long-term outcomes, remain limited because it's a fairly new procedure. So here we report our early experience with OAGB at a single center in Singapore. So this is just a descriptive study of a prospectively collected data from 133 patients. We collected the patient's demographics, the baseline comorbid diseases, perioperative outcomes, including weight loss, and postoperative complications. So as for the results, we only started doing OAGBs from September 2019 up to present. And before deciding to offer OAGB, we also discussed with the patient the sleeve gastrectomy and the traditional RYGB. The pros and cons of each procedure was discussed with the patient, and we let the patient decide. And to date, around 130 OAGBs have been performed in our center. So for the baseline demographics, the average age of the patient was around 40 years old. The average weight is around 117 kilograms. There are more female patients from the cohort, comprising around 63%, and this is a multi-ethnic demographic. So most of the patients are Chinese, Malay, and of Indian descent. As to the BMI, the average BMI of the patient is 43.47. Majority of the patients belong to the morbid obese category, comprising of around 70%. A handful are super obese who have more than 50 BMI. As to the metabolic burden, a majority of them actually present with not just obesity, but with other metabolic diseases. Around half of them would present with diabetes as well. 47% of them had hypertension, and 41% had hyperlipidemia. As to the type of surgery, the most common bypass length that was used was around 150 centimeters to 200 centimeters. There were a handful of patients, mostly on the super obese category, wherein we would do a 450 cm common channel, and all the rest was bypassed. Regarding the operative time, the average operative time was around 113 minutes. We noted that this was not correlated with the patient's BMI, but it did correlate with the length of bypass that was done to the patient. As to the weight loss outcomes, it is of note that this is a fairly early cohort. Only a handful has reached more than a year of follow-up. So most of them are just coming back for their 6-month follow-up, for their 12-month follow-up. But we do see a decreasing trend in their weight. So the average weight in kilograms was around 118 kilograms pre-op, and at 12 months, a lot of them would decrease to around 67 kilograms. Now, the percentage of excess weight loss and the total weight loss was also increasing at 6 months and 12 months. So again, this just shows the trend of the previous data on the previous slide. As to the post-operative complications, we did note around 7 patients out of the 133 patients developed post-operative complications. So we had 2 patients who had bleeding. One of them required reoperation from bleeding on the staple line. One patient presented with a delayed leak on post-op day 20, and that patient required revision to an RYGB. And then 5 patients also presented or developed marginal ulcers. This was after symptom-based investigation. And all of these patients were treated medically with just proton pump inhibitors. So in conclusion, OAGB seems to be a technically less demanding surgery compared to the traditional gastric bypass, as we all know. It offers a short operative time. It seems to be offering good weight loss for the patients. And at present, it's currently endorsed by both the ASMBS and the IFSO. Now, regarding the cons of the procedure, there's a lot to be determined regarding the long-term outcomes from this procedure. So we don't know if the bile reflux of these patients, if bile reflux would play a big role in the long term, if more patients would develop marginal ulcers in the long-term follow-up, as well as nutritional complications from the OAGB. We know that this is a malabsorptive procedure, so these patients require closer monitoring and a more aggressive treatment as compared to those patients who would get the traditional sleeve and RYGB. And the optimal bypass length has yet to be determined. Thank you.
Thank you very much. I have one question. So it looks that weight loss 6 months after OAGB is better than compared to the other points. So that means did you change some procedure or system not related? Those things.
Actually, the weight trend that I showed earlier, as we progress further on into the patient's follow-up, meaning patients that we have data for after 1 year, at 12 months, at 18 months, there's only a handful of them. So it's not really representative of the whole cohort. So not a lot of patients have reached their 1 year follow-up. But if we do see the majority of those patients who have reached their 1 year follow-up, the weight trend is going down. Yeah.
Do you know the reason why weight loss effectiveness is down, so 6 months to the 1 year? Do you know the reason?
We don't really, the management of these patients, as we see them during their follow-up, we do a standard protocol for each patient, actually.
Yes,
So,
because that situation is very curious, I think.
Yeah, we probably would need to
6
investigate
months,
more.
12 months, this increase, at that plateau or little increase?
Mm.
So please check again.
Yes, I think the more patients that we get who come back for their 1 year, 2 year follow-up, the more patients, the more data that we gather, it's probably better to present the data then.
My question is, again, it's been reported and discussed earlier in our previous sessions in the main hall, limb length.
Yes.
So the decision to make the limb length is on what basis?
So this one is also variable because several surgeons do the procedure. So it depends on the patient's BMI. The heavier the patient, the surgeon would tend to do a longer limb length of around 200 centimeters. The lower the BMI, less than 35, they would prefer to do the limb length at a shorter length, at around 150 cm. And we did note that some surgeons would prefer to measure from the ileocecal valve and just measure 450 centimeters of a common channel, and regardless of the bypass length, just do that for the super obese.
Okay, that's interesting.
So it was variable.
Yeah, so I think you should look more into that. You should look more into that aspect. And I'd like to comment that your study, since Singapore is a very multi-ethnic country, you were isolating ethnic groups.
Mm-hmm.
Maybe looking into the individual stratification of the ethnic groups themselves and how long the limbs are given. Maybe that's another study to go with, right?
Noted.
Okay, thank you very much, Doctor.
Thank you.
Okay, so our next presenter is from India. They will present steatorrhea after a blessing or a challenge, prospective study of 70 patients in 5 years. Our presenter is Dr. Shah Radhika. Thank you.
Good evening, and thank you so much for giving me this opportunity to present my abstract. So I'm going to present a case. I think we'll have to change. It's not the presentation.
Yes.
It's the second presentation.
Yeah, could you check steatorrhea after a blessing?
Yeah.
Oh, she's presenting 2 papers. Okay, thank you.
Yeah. So
Let's start again.
Yeah. So steatorrhea after OAGB, a blessing or a challenge. It's a prospective study of 70 patients from our center in 5 years. I have no disclosures. So OAGB, as we all know, earlier known as MGB, is becoming more popular as a hypoabsorptive procedure. Malabsorption varies as per the bypassed biliopancreatic limb. Steatorrhea is a bulky, foul-smelling, greasy stool caused by malabsorption of fat. It could be because of colonic fermentation and putrefaction, excess gas formation related to fermentation of carbohydrate in the intestinal bacteria, rapid transit of food. Steatorrhea is one of the known effects of OAGB, and it does contribute to a better weight loss by less energy absorption. However, it can sometimes become a challenge to the patients. Steatorrhea after OAGB could be because of wide anastomosis, emptying of stomach, faster transit through intestine, and relatively lesser intestine available for absorption. Rapid stimulation of hormones, the benefits are rapid stimulation of hormones secreted by the terminal ileum, fat malabsorption, improvement in diabetes, maintenance of weight loss, and improvement in lipid profile of the patient. However, it does have some challenges like absorption of fat-soluble vitamins could be a challenge, some extent of protein malnutrition, increased urgency and frequency of bowel movement, foul-smelling stools can become a social challenge to the patient, and occasional diarrhea. So factors that affect the extent of steatorrhea could be pre-op, small bowel motility, gut microbiota, pre-operatively and change post-operatively, and more potential of infection due to less acid and use of antacids post-operatively. So the purpose of the study was to understand the impact of quality of life in patient with OAGB in the Indian dietary preparations, and to modify the dietary preparations in order to minimize steatorrhea and keep nutritional rich content and maintaining the palatability. And hence we studied 70 patients who underwent OAGB at our center from 2015 to 17, and data was collected prospectively and analyzed. So out of patients that were included in the study were with the who underwent standard OAGB procedure with 150 centimeters of BP limb. Only primary OAGB patients were included. Mean BMI was 43.4, mean age was 44, and 30 males and 40 females were included. Parameters which we noted were a percentage of excess weight loss, vitamin D, and serum protein levels. Questionnaires related to symptomology of steatorrhea was taken, which included malodorous stools, oily spotting, urgency, incontinence, and challenges in interpersonal relationship of the patient. So percentage mean excess weight loss at 2 to 5 years was 79.5%. Vitamin D was low at baseline as well, that is 29, which remained lower with mean of 25 at 5 years. Serum protein were 6.9 at baseline, which at the end of 5 years was 6.2, and standard supplementation of proteins and vitamins were advised to the patients. However, malodorous stools, 49 out of 70 patients reported with malodorous stools, which we further categorized with the questionnaire by dividing it into occasional acceptable, 29 out of 49, frequent unacceptable were 13 out of 49, and frequent troublesome unacceptable was 7 out of 49. Oily spotting, 10% of the patients, that is 7 out of 70, reported with oily spotting, foul smelling, and which was a social discomfort with soiling of clothes. Urgency and incontinence, 7 out of 10 again, 10% reported. Mostly it happened after the ingestion of high-fat food. Out of these 7 patients, 2 patients reported of use of diapers, and 1 patient reported soiling of clothes during the travel due to the urgency and unavailability of nearby toilet, of course. Always looking for the toilets was reported by the patients. Challenges in interpersonal relationship. I know we all know that there are various reasons that affect the interpersonal relationship. However, this malodorous flatus was one of the factors that we found, and we further categorized it into different categories like malodorous flatus. Did it affect the intimacy in the room? 7 out of 14 reported. Challenge in sharing of the same toilet, 5 had the challenge doing, 5 out of 14 reported. And spotting and incontinence affecting intimate relationship, 2 patients out of 14 reported this problem. So treatment offered was dietary modification in the form of more protein, fiber, and less of fat in diet. Because the patient group was Indian, we did it in an Indian scenario. The Indian foods, as we all know, is more of high fat and high carbohydrate. Both are like a challenge after any bypass procedure. It induces dumping and steatorrhea. So modification was given to the patient. Various recipes were advised. Addition of pre and probiotics were done to these patients. Use of anti-amoebic, antibacterial drugs, antidiarrheal medications, and revision were offered. 2 patients were converted from OAGB to sleeve for intractable diarrhea and incontinence. So limitation of the study is small sample size, single center study, and lack of standardization or grading of the symptoms. So I would like to conclude saying that OAGB induces satisfactory weight loss at 5 years. However, the quality of life may get affected due to different symptoms related to due to steatorrhea. Dietary modifications can convert this challenge into a blessing of weight loss. Thank you.
Thank you very much, Doctor. So it's quite interesting that you were also looking into intimacy, intimate relationship as a factor. Maybe you should look into the discussion on standardization of the scoring system. My question is there only one person doing the scoring? I mean, when you talk to the patient, there's only one person who's trying to look into that?
The history, you mean the
Yes, or are there different persons trying to get the data?
Yeah. So it was only a single person because it was a small group of patients, and because a single person could get an exact idea and the question, because it was just a questionnaire, so only one person did it.
Okay, that's a big help for the study because if you have multiple persons, you'll have varying degrees of bias.
Exactly.
But again, with a single person, you can still have bias. So you'll have to standardize that.
Yes.
Thank you very much. So for the next presenter, actually, this presenter after he was requesting, since you're the next one after him, would you like to continue on stage for your next case?
Sure.
All right. Thank you very much.
Okay.
So the next case is the 50-kilogram weight loss in just 20 days. Is it possible? A rare case report of preoperative preparation.
So today I'm presenting another report of a 50 kg weight loss. I have no disclosures except for patient has given me the consent to use the photographs. So we all know that preoperative weight loss is an established science, and it induces around 5 to 10% weight loss maximally. So preoperative preparation is a key for safety, to improve results and to improve compliance of the patients. There are various reports and papers published which explain that preoperative preparation is essential for any patient undergoing bariatric surgery, and it reduces the size of the liver. However, around 80% of the size of the liver is reduced between 0 to 2 weeks after during the preparation. It also decreases the operating room time, in less intraoperative blood loss. So these are the benefits of preparation of the patient. Along with that, optimization of comorbidities can be done better in preoperative preparation, and it increases the patient's understanding of postoperative dietary requirement. We get the opportunity to correct any nutritional deficiencies and prepare patient physically and mentally for the surgery and postoperative lifelong journey. However, there are some challenges in some cases, like this. In this case, the objective of our report or the case was to evaluate, modify the protocol of preparation of patients with anasarca and BMI of 67.3 kg per meter square. This is a rare case report of a lady with 44 years of age with BMI of 67.3, weight of 163.8 kgs. She was an Indian. She had a severe sleep apnea of SpO2 about 78. Anasarca, hands and legs were almost swollen and the fluid was oozing out and the skin was so hard as stone. And all other comorbidities like difficulty in walking, difficulty in taking few steps, breathing, etc. with diabetes, hypertension, hypothyroidism were present. So very interestingly, when we took the history of the patient, she reported the weight gain, rapid weight gain in 5 months, that is around 38 kgs, that is from 125 kgs to 63.8 kgs weight gain happened in just 5 months, out of which 31.8 kgs was reported only in 2 months. And this weight gain suggests the fluid retention. So anasarca, you can see the anasarca in the lower body, lower abdomen of the patient. So preoperative evaluation was done. She had grade 3 fatty liver. Surprisingly, her renal function and 2D echo were normal. Total body water was 75 kgs. We did it on the Tanita body composition. Her sugar levels were high, slightly high, and alkaline phosphatase was on the higher side with HbA1c of 10. So pre-operative preparation was offered to her in the hospital, and these are the drugs, list of drugs that we gave her. She was on antifungal, antibiotic and anti-inflammatory medications for first 5 days on admission. Injection furosemide 40 milligrams was given twice a day. We added dulaglutide 0.75 once a week, and topiramate was added. Dapagliflozin was given to induce glucose-urea along with spironolactone 50 milligrams once a day. Then standard VLCD, which was made possible with these drugs, around 800 to 1000 kilocalories per day. Spirometry was done every 2 hourly, balloon exercise every 2 hourly. Daily weight monitoring was done, daily electrolyte monitoring, blood glucose monitoring every 6 hours. Ambulation, we tried ambulating her after every 2 hours, and daily SpO2 BP pulse were monitored. Challenges and role of a team was VLCD was a big challenge, but however addition of pharmacotherapy made it easy. We tried making the diet a little more palatable, various options and recipes were added. More fluids were given considering the addition of the medications like dapagliflozin and diuretics. Counseling of the patient was done for the effects of pharmacotherapy. More fibers were added. Soluble fiber supplements were given so as to counteract the effects of some drugs. Diuretics, we added a special sugar-free electrolyte solution as she was on a lot of diuretics so as to prevent the imbalance of the electrolytes in the body. And the correction of electrolytes as patient was on high diuretic. Counseling was done for extensive pulmonary exercise, physiotherapy, walking, breathing exercises, etc. Here is the weight chart that we saw that massive weight loss happened in the first 10 days. You can see from 163.8 kgs to 132 kgs, which continued, and the patient came down to 113 kgs on day 20. Day 21, she underwent sleeve gastrectomy. As her anasarca was improved, weight loss was 50 kgs in just 20 days. SpO2 improved to 95%. 6 weeks later, we followed up with the patient where patient lost 60 kgs total, considering pre and post operatively. SpO2 improved, her total body water dropped from 75 kgs to 31 kgs, and there was improvement in anasarca. 6 months later, patient, the breathing improved, resolution of all comorbidities are seen, and the BMI dropped to 39 from 61, and the total body water further dropped down to 28.8 kgs. And this is the sequential photographs of the patient. You can see how the patient lost weight. Of course, after coming across this case, we did some research of such a massive weight loss pre-operatively for the patients. We came across only 2 cases where the patient lost around 40 kgs weight, and the cases are reported so far, and these cases illustrate how fluid retention in severe obesity can differ from the traditional heart failure in terms of clinical assessment and management. However, severe obesity can result in insidious fluid retention, which can be easily overlooked until large volume of fluid is accumulated. Cardiac abnormalities are usually found in these patients, but may be relatively subtle and leading current debates in definition and classification of heart failure. However, I would like to conclude stating that obesity can induce anasarca and fluid retention. However, in absence of any abnormal cardiac and renal function, such a massive anasarca is uncommon. And the case shows approach to the patients of anasarca and morbid obesity in first case, and is the first case report of such a massive weight loss. I would like to give a take-home message that cardiac evaluation could be normal in such patients with BMI more than 40. However, fluid retention could be a manifestation of mild cardiac dysfunction. Aldosterone diuretics is the mainstay of the treatment but cannot be the sole treatment. Addition of pharmacotherapy would be needed for such patients, and monitoring electrolytes renal function is important in such patients. Multidisciplinary approach is a must, and preparation of such patients can be done better in the hospital setup. 50 kgs weight loss is possible in 20 days in such patients, and this is probably the world record of highest weight loss in short duration. Thank you.
Thank you very much. I have one question. So, during for 20 days, 50 kilogram decreased in this case. You measured body composition for 20 days between the first day and the 21st days. Water is decreased about 40 kilogram. And I want to know the remaining 10 kilogram is muscle or fat or both. I want to know.
So rest 10 kilograms is the fat, of course, a fat loss for the patient. We did the body composition on Tanita, and then we could see the fat loss and water loss. Thank you.
Thank you. I have a question. Since the patient has already lost 50 kilograms in 20 days, shouldn't we consider maybe going continuously with non-operative weight loss, since there's already a
It's a very interesting case, but like it's mentioned, that was a fluid retention, and then further there won't be the further weight loss in the same manner later. And as her BMI was quite high, I think bariatric or metabolic surgery would be the best treatment later for the long-term maintenance and to prevent the recurrence of anasarca in such cases.
Okay, so that's a good angle of looking at things. Fluid retention can increase the weight of a patient or increase the BMI, and taking into heart that part, maybe if that's why we cannot base everything on BMI.
Yeah.
Alone.
No, yeah.
So in the decision making. So thank you very much, doctor.
Thank you.
Okay, for our next presenter, he will be presenting Defying the Odds, a national perspective of bariatric and metabolic surgery amidst the COVID-19 pandemic. Our presenter is Dr. Darwin Salonga.
Good evening. Thank you very much to IFSO for giving us the opportunity to present our papers tonight. I am Dr. Darwin Salonga on behalf of my co-authors for this simple paper during my fellowship training in Taiwan, Defying the Odds, a national perspective of bariatric and metabolic surgery amidst the COVID-19 pandemic. It was on December 29, 2019, when the first 4 COVID-19 cases were reported from local hospitals in Wuhan. This was published in the Early Transmission Dynamics in Wuhan of Novel Coronavirus Infected Pneumonia in the New England Journal of Medicine. And by April 2020, IFSO released the guidelines or recommendations for metabolic and bariatric surgery during COVID-19, that all elective surgical and endoscopic cases for MBS should be postponed during the pandemic. This minimizes the risk for both patients and healthcare team, as well as reducing the utilization of unnecessary resources such as beds, ventilators, and PPE. In addition, postponing these services will minimize potential exposure of the COVID-19 virus to unsuspecting healthcare providers and patients. In this study, we review and share the preparations, healthcare policies, and protocols made by Taiwan against COVID-19. With these important steps, Taiwan continuously performed elective bariatric and metabolic surgeries amidst the pandemic with 0 healthcare worker infection for the whole year of January to December 2020. For preparing for the pandemic, containing an outbreak at an early stage affords a greater chance of success rather than a delayed response, and clearly puts less strain on the healthcare system. Taiwan actually had 16 years of pre-preparations. Back in 2004, there was a SARS outbreak. They formed the National Health Command Center, which is composed of the Central Epidemic Command Center, Biological Pathogen Disaster Command Center, a Counter-Bioterrorism Command Center, and the Central Medical Emergency Operations Center. It is part of a disaster management center that focuses on large outbreak response and acts as the operational command point for direct communications among central, regional, and local authorities. Just 2 days after the announcement from the World Health Organizations, Taiwan started to assess all the passengers from Wuhan, China, assess for fever and respiratory symptoms prior to deplaning. After merely 5 days, they included passengers with 14 days travel history to Wuhan. They were screened for 26 viruses, including SARS and MERS, and they were home quarantined or hospital requiring medical attention, depending on their assessment. By January 20, 2020, the Taiwan NHCC was officially activated. It was also in Taiwan where there was the first confirmed COVID-19 case outside of China. By January 23, 2020, Wuhan residents were completely banned entry to Taiwan, and travelers from China were made to submit electronic declarations of health prior to entry. All direct flights from the provinces of Guangdong and Xinjiang and tour groups to and from Hong Kong and Macau were also suspended. By February 6, 2020, all Chinese nationals and international cruise ships were banned. Foreign nationals who traveled to China, Hong Kong, and Macau in the past 14 days were also banned. For the healthcare policies, Taiwan hastened the production of surgical masks in anticipation of its increase in demand to protect the healthcare workers and, most importantly, to prevent the spread of the virus. They distributed and limited 3 surgical masks per person per week to all Taiwan citizens. They were able to produce 10 million masks per day by February 2, 2020. And commercial stores and pharmacies were not allowed to sell surgical masks. Also, on February 24, 2020, Taiwan banned all its doctors from non-essential travels overseas. For the scrub suits, the hospital provided official scrub suits. Upon entry, they must change to these scrub suits. Upon exit from the operating room, they are to leave with a different color-coded scrub suit. Upon end of the rounds, clinic or ward work, the scrub suits are left in the hospital. For the surgical mask, all healthcare workers are required to wear surgical mask both inside and outside the hospital, depending on the Taiwan government daily advisory. This is just an algorithm of the healthcare policies for healthcare workers. So there is a designated entrance for doctors, wherein there was thermal scanners and individual temperature check. Risk factors includes fever, upper respiratory tract signs and symptoms, and close contact with a COVID-19 confirmed case. If they are cleared, they are allowed to report to work. If they're not cleared, they are sent to the ER isolation, wherein they can undergo portable chest x-ray, nasopharyngeal swabbing, and an infectious disease referral. So for our methodology, we perform a retrospective review of all screen and COVID-19 cleared elective bariatric and metabolic surgeries done in the whole country using the national database from January to December 2020 and comparing them to the same time period in 2019. The authors analyzed its trends and measured the mortality rates, average length of hospital stay, and readmission rates for both years. This is the algorithm for patients. So an appointment database is used prior to entering the hospital. A thermal scanner, as mentioned, an individual check. Risk factors were also evaluated. So if they were all cleared, the patient will undergo preoperative screening. If they're not cleared, the patient will have to undergo portable chest x-ray, swabbing, and infectious disease referral. If the patient is cleared, he can undergo the operation. But if the patient is not cleared, the surgery is deferred and managed accordingly by the infectious disease and a mandatory 14 days home quarantine after discharge. All the patients after the operation, during the operations, there is clearance from the infectious disease. The OR team wear the acceptable standard PPE, and the hospital suite had a HEPA filter OR. After the operation, during the operation, there's a limitation in the companion. The patients always wear the surgical mask, and the standard bariatric protocol was observed. On follow-up, there was an online and telephone appointment, reminder by a case manager, and free online consultation. It's also available. All cases were done laparoscopically, and all staff wore personal protective equipment, leveling depending on the risk assessment. The operating theater was HEPA filtered, proper air ventilation, and standard positive pressure operating room. For the results, comparing to the 2019 cases, we had a total of 3,133 cases versus the 3,271 in 2019. Breakdown as follows. Average BMI is 35.25 and in 2020, and an average BMI of 35.80 in 2019. There was an only 4% decline comparing both years. For the type of elective surgeries performed, for the breakdown, there was a decrease of 293 cases for the LSG at 1,712, or only 14.6%. We had 100 in 2020 of proximal jejunal bypass with sleeve comparing to 97, 7 cases of DJB comparing to 26 cases in 2019, and 125 cases of gastric bypass compared to 119 in 2019. There was no significant difference in the mortality rate. There was also no significant difference in the readmission rates on both years. As mentioned, no reported cases for healthcare workers with COVID-19. This was the 2010 to 2020 numbers of types of surgeries for bariatric surgery in Taiwan. As you can see there, the trend is around 2,500 to 3,000 for the past 5 years. For the discussion, a pre-arrival screening was done. There was only a designated entrance and exit for patients and doctors. Thermal scanners were strategically placed with confirmatory individual checking of body temperature by a contactless thermometer. Patients with 37.5 degrees Celsius were not allowed to enter the building and directed to the emergency room. No mask, no entry. This is a simple but valuable mitigation measures done early in the course of the pandemic and was done because of the availability of surgical masks to all citizens. The government made sure supply was adequate early in the course of the pandemic. Hence, patients without surgical mask were not allowed to enter the hospital.
Doc, 30 seconds.
For the preoperative screening, I also already mentioned this in the algorithm. So there were no reported cases of postoperative patients developing fever of unknown etiology, upper respiratory infections. Hence, none of our postoperative patients needed COVID-19 testing. There was one case of staple leak from an LSG patient with Cushing syndrome who was successfully managed by reoperation. There was no difference in the length of hospital stay of patients from this year compared to last year and maintained no mortality. For the limitation, this article only covers elective operations in the field of bariatric and metabolic surgery. A bigger sample size can be obtained if census from other surgical fields are added in the future studies. And strong and collaborative effort of the government, healthcare policies and measures should likewise be based on other multiple factors like local community transmission rate, travel guidelines, availability of resources, and nationwide health insurance. So in conclusion, our experience highlights that within stringent and well-planned healthcare policies, good governance, and cooperation of all sectors, Taiwan has contained serious and debilitating effects of the pandemic. Compared to last year, we had a slight decrease in case operations, but have managed to ensure patients and healthcare workers' safety. We continue to provide and innovate means to fight COVID-19. Thank you very much.
Thank you very much. Last year's IFSO APC's national report clearly demonstrated COVID-19 pandemic did not influence a number of bariatric metabolic surgery in East Asian countries, including Japan, China, Korea, and Taiwan. And those data now has been published in obesity surgery in this year. I want to know, you show this year's number in Taiwan is little decreased. If you know the detailed data, so I want to know.
For this year, doctor?
Sorry, 2021.
For 2021, actually the census already increased. Because some of their patients were already coming back compared to 2020. There was already increase in census.
Oh, really?
Yes, sir.
This year is a little decrease.
No.
Oh, really?
Yes, sir. They were doing more surgeries now compared to last year.
This goes to show that for other countries it was business as usual, huh? Despite the pandemic.
Yes,
that's where national preparation is important, and I think we should learn from that for any future pandemic. Thank you very much, Doctor.
Thank you, sir.
And now for our last presenter. Unfortunately, we have presenters from China unable to attend. And Singapore also was unable to attend. So our last presenter will be showing us the stapled sleeve gastrectomy with duodeno-jejunostomy. May we call on Dr. Chung Yuna, correct? Yes, okay.
Okay, so hi again. My name is Dr. Yuna Chung. This is a stapled sleeve gastrectomy with duodenal jejunostomy. And I believe this was my first case that I performed, and it's a narrated video. The video isn't playing. Can we turn on the sound?
Perigastric vessels at the greater curvature 4 centimeters proximal from the pylorus are ligated for window formation for future stapling their sleeve formation. Adhesiolysis of any posterior adhesions of the antrum is performed for sufficient mobilization of the duodenum. While preserving the right gastroepiploic and right gastric vessels, dissection was continued to expose the supraduodenal vessels. With tractioning the duodenum downwards, tunneling of the posterior side of the duodenum was done with the finger retractor, and a tape was pulled through to facilitate stapling for transection. A curved tip stapler was used for transection while rotating the head distally to obtain enough anterior space for the stapled anastomosis. The duodenal stump was reinforced. Marking of the ingula his was done for future identification of the left cruce muscle from a posterior view. The first couple of staplings were performed with a higher stapler height. Adhesiolysis of any posterior adhesions was done for equal stapling of the anterior and posterior walls of the stomach. Performing stapling first in an in situ manner helps equal stapling due to the intact anatomical structures. When approaching the EG junction from the posterior view, the ingula his can be seen, and with further dissection, the left cruce muscle was fully exposed. Final staplings. Final staplings were performed with care to not form any dog ears. The remnant stomach was resected in a downstream manner from the upper post of the upper pole of the spleen. Performing sleeve gastrectomy in situ enables a clear surgical view of the short gastric vessels even in patients with a higher BMI and can help prevent splenic infarction. Serosal suture of the staple line was performed to prevent bleeding. A suture for traction was done at the ends of the transected duodenum.
I'm sorry about the quality of the audio.
Division of the omentum towards the duodenum was done to reduce anastomosis tension. The jejunum was measured 200 centimeters from the trite's ligament and an entry hole was made. Stable duodenal jejunostomy was done with a tan cartridge. The common entry hole was closed continuously in one layer. An anti-reflux suture was done of the A-loop and the antrum. Closure of the Peterson's defect was done with non-absorbable sutures.
That was the end of the presentation.
Thank you very much for excellent technique of sleeve DJB. So I have one question, two questions. First question is, this presentation title is stapled sleeve gastrectomy with duodenal jejunostomy, meaning that's all stapling method, including duodenal jejunostomy, meaning?
We used to do the duodenal jejunostomy in a manual manner with an entry hole about 2 centimeters, but we incorporated the linear stapler and then closed the common entry hole with one layer suture.
So what stapler? Why you did not use entry hole closure using stapling?
A stapler. We wanted to be safe first.
But it's usual. It's okay. And second question is stapling fast technique is almost established in 2010 by Chile's bariatric group, especially Professor Bossa. And that technique problem is bigger sleeve tube, and if the bleeding so under the gastric tube, at the time very difficult to have a operative field. So that technique have two problems. How do you think about that problems in the stapling fast technique?
That's a very difficult.
I think it was, you were saying about the remnant stomach being larger diameter, is that it? No, larger diameter.
Because before this is whole stomach.
Not dissecting the greater curvature first.
Yeah, cut.
Okay.
So that's usual. So in Japan also the young bariatric surgeons started to perform the stapling fast technique. First he think that's his own technique, but previously almost established in 10 years ago.
Well, I did not think that it was a new technique, but
maybe Dr. Kim has his opinion.
Well, Dr. Yongjin Kim does perform all of his sleeve gastrectomies with stapling first, and I believe that I first started performing with a dissection of the greater curvature first, but when I applied this technique, and I've been performing all of my sleeve gastrectomies with stapling first, it's much easier to identify the left cruce muscle from the posterior view, especially in male patients with a high BMI. It seems much safer, in my personal opinion.
technique is not so easy to twist the gastric tube. That's a big merit, I think.
I agree.
Yeah, I'm curious, doctor, with regards to the suturing technique you were using, I noticed that you were using barbed sutures almost throughout the entire phase of your procedure. I recently talked with the provider of the barbed suture, and they mentioned in their they had a disclaimer that they do not advise using barbed sutures on lumen anastomosis. What's your take on that?
Well, although my career as a bariatric surgeon is like 2 years, I think, and I've always used continuous barbed sutures for closing all of my anastomoses, and I don't I don't include the mucosa. I leave that part out.
Okay, so you go for steromuscular?
Yes.
Okay. Including the one with the closure of the openings, right?
Yes.
Okay. Yeah, so I think that's it for everybody. Thank you very much, doctor.
Thank you.
Okay. Yes. Okay. Yes, we'll be having, Dr. Ota and I would like to conclude the last session of our IFSO APC Congress in the Narra room. And we'd like to, first of all, point out that the presentations you've given, they're all, we can go for developing them even more. We've seen really promising studies on the economics. We're also seeing new techniques that some of us haven't thought about, actually. We do not employ the usual. But our take on this is that you, as young surgeons, continue to pursue the development of bariatric surgery. Of course, what our bosses have been teaching us, we will develop new things later on down the line and go on and do some more, so to speak. So thank you very much for coming. We'll be giving away our certificates for your participation, and after this, let's have a picture taking for remembrance. Okay, so I'd like to call on Dr. Daniel Liu, Dr. Yawei Huang. Daniel Liu? Yes, thank you. Okay, you can go to the front. Can we have the lights on for picture? Dr. Jennifer Yang, Dr. Kiwei Cheng. Sorry, Kiwei. Did I pronounce it right? Cheng. Okay, all right, Cheng. Dr. Sheng Shi Chen. Okay. Dr. Yuna Chung. And Dr. Darwin Salonga. There's, for Dr. Melissa. Yeah. Sheng Shi Chen. Melissa. I think they left. Yeah, okay. So, Dr. Ota. Could you turn off the cassette LCD? Projector. Press nyo lang letter B. Para lang mag-black. Okay. Yeah, we're done. Okay, bye-bye. Thank you very much. See you in, where are we going next year? No, Naples. Naples, yeah. You do your studies and see you in Naples. Thank you, everyone. Are there anyone going to anywhere else, like R&R in the Philippines? No one? Okay. Picture? Sige. Hindi. Sige.
Hi.